some quick notes. This is our largest meeting to date, which is a fantastic success. So thank you everyone for registering. Wonderful. And we're actually going to start with a short video that the AMP team put together. Just one thing, what you'll see was put together in the last few days. So it's missing our partner logos. We'll add that and we'll circulate it at the end of the meeting. So Orion, are you okay if we start the video? Great. Good. So congratulations to everyone in the room. And thank you once again to those malaria control programs and partners that provided photos. What we'll do is we'll circulate a version of this with the partner logos on, the RBM logo on, right after the meeting. So thanks once again. So I just wanted to run through two technical slides before we start. So this is the slide on interpretation. So if you're sitting in the meeting room, you have in front of you those headsets. So channel 1 is the English channel and channel 2 is the French channel. And then if you're a remote participant joining by Zoom, the same. You'll have interpretation options at the bottom, and you can choose either channel 1 for English or channel 2 for French. So we can move to the next slide. Good. And then if you're experiencing technical difficulties, any technical problems, if you can send an email to or chat in Zoom or email to that info. So either put the problem you have in the Zoom chat or in the info email that's there. Perfect. Good. So I'm going to ask William from Movenpick to come up. He's just going to give us a quick briefing on security here at the Movenpick Hotel.
Good morning, distinguished ladies and gentlemen. My name is William. I'm the Assistant Head of Security. So this is just a short security brief on the measures that we've put in place to ensure your safety while staying with us. So the first thing is that the hotel has an advanced fire detection system in case of any fires or any smoke detected within the hotel premises. All our rooms and corridors are installed with smoke detectors in case of any smoke or any fire. If an alarm is activated, our in-house security team will check, and if anything is found, then the overhead speakers will be used to offer that information. We also have a directional signs marked exit, which will lead you to the fire assembly points, which are located either at the Maua Gate or Mkungu Gate. We have trained fire marshals and first aiders who will assist accordingly. I kindly do not use elevators in case of any fires. We also have a clinic within the hotel in case of any complications. We do not have any plan for a fire drill today, so if the alarm goes off, kindly take it seriously. We also have armed police in the ground in case of any external threat. While you're attending this meeting, we urge you to wear your badges, if you have any provided for you, to easily identify you. Please take care of your personal belongings. If you're staying with us in-house, kindly use the safes provided in the room. Before I wind up, our washrooms are along the corridors at the farthest end. If you have your car parked at the basement, kindly note that we are not charging for any parking fees. With those, thank you and have a productive meeting, unless there's any questions. Thank you very much.
Good. Thank you very much, William. Just a correction. So this screen isn't working. So sorry, the French translation is on channel 3 on your headset. So any French speakers, you'll find French on channel 3, not channel 2. So very quickly, we just wanted to update the room on a few points. So the feedback from last year, participants asked for more time for networking. So we are going to end today and tomorrow at 4:05, and that will give you 2 hours time before the cocktail for meetings and for networking opportunities. As well, we just ask if you do want to do a side meeting, if you could do it either during the tea break, during the lunch break, or after the meeting, so not pulling participants out of this meeting so they can benefit from the totality of the meeting. We'll have an evaluation at the end of day 2. So as we're moving through the meeting, if there are things you see you really like, if you can kind of note those and things you feel should improve, please put those into the evaluation. What we've done is on people's name tags, if they're a speaker, they'll have a little dark circle in the corner. So if you are interested in a particular presentation and making contact, you should be able to find them because you'll find a little black tack on their speaker note. And then quickly, the email details, or sorry, the internet details are at the entrance. And then we'll have lunch and we'll have cocktails down at the pool area where you had breakfast. So in the past, we used to actually pass the microphone around and ask everyone to introduce themselves. We've become too big to do that. What we wanted to do today was just recognize the country delegations that are here. So I'm just going to list the countries that are physically in the room alphabetically. And if you could stand up and wave, and that allows participants, if they're interested in meeting with Benin, to meet with the Benin team. There's a few countries that are joining online, so we won't have an opportunity to introduce you, but I just wanted to start with, could the Benin team just stand up and wave your hand? Welcome. Burkina Faso? Great. Burkina Faso? Could you stand up just quickly, just so people can see you if they want to come over and talk to you? Great. Burundi? Welcome. Chad? Welcome. DRC team? Welcome. Ghana? Liberia? Madagascar? Bienvenue. Malawi? Welcome. Mali? Bienvenue. Mauritania? Okay. Mozambique? Welcome. Nigeria? Welcome. Pakistan? Welcome. Rwanda? Welcome. Senegal? Bienvenue. South Sudan. Welcome. Togo. Bienvenue. Uganda. The United Republic of Tanzania. Welcome. Zambia. Welcome. And then finally, we wanted the Rollback Malaria Partnership and the RBM Partnership and Malaria team just to stand up and wave, because I know a number of countries in the room will want to say hello to you. So there's Dr. Daddy and colleagues at the back and Michael Charles. Welcome. Good. So we're going to, I'd like to introduce our first speaker. I just wanted to check, Oriane, has Dr. Joseph from Ministry of Health Kenya arrived? No. Okay. So we were going to have a welcome from Dr. Joseph from the Ministry of Health Kenya. He's probably arriving late. So I'd like to invite Mohammed Mukir, who's the director of IFRC's Africa region. He's based here in Nairobi to give us a few welcoming remarks from IFRC. So welcome, Mohammed.
Good morning, ladies and gentlemen, colleagues and friends. It really gives me great pleasure on behalf of the IFRC network. I would say the IFRC network, the International Federation of Red Cross, Red Crescent Network. That means the Secretariat and our 191 members that we have been hosting the Alliance for the last since 2005. And we are committed to continue to host the Alliance because we believe that we need to put all hands together. We need to put all resources together. We need partnership to make sure that we are helping not only malaria prevention, but all the epidemics and pandemics. So that is our commitment as a federation to keep hosting the Alliance and to keep working hard to make sure that we are increasing the numbers and quality of the partners. Maybe colleagues, specifically about Africa, allow me to make few remarks. Red Cross, Red Crescent in Sub-Saharan Africa, we are having national society in 49 countries. We have 18,000 branches. We have 3.8 million volunteers, and we have more than 13,000 staff. And we work collectively as a Red Cross, Red Crescent family in Africa, meaning the African National Society with the Secretariat and governments, especially Ministry of Health. And we developed quite good approach for integrated pandemic and epidemic management, prevention, readiness, preparedness, and response. And we basically look at endemic, pandemic and epidemics not in a singular way. For example, I mean, when COVID-19 hit all of us, through the Red Cross, Red Crescent Network, the volunteers, the branches, and national society working cross-border with each others, we managed to provide services to more than 450 million people. And this is not only curative services. We did that one. We did ambulance services. We did preventive services. We did the hygiene promotion and sanitation. And we did livelihood support as well, because we, by the time, of course, such an epidemic has huge impact on livelihood systems. And that is the way we're looking to integrate cholera together with malaria, together with dengue fever and other issues and challenges that the African National Society is facing, but specifically the issues that are driven by climate change and waterborne disease. We deal with that in integrated way, and our big advice to all of the partners and people who work with us in Africa, especially community members and national governments, that we continue work on that way, because this will be the most efficient way to handle epidemics and pandemics. Ladies and gentlemen, maybe my final point of remark is about we need all hands on deck. I think, as you can imagine, we are now handling about 30 flood operations, all of them bringing issues related to malaria, related to cholera, related to dengue fever. And I think we would like to bring the urgency. In Africa, there is a huge urgency, actually, when it comes to this community level, predictable endemic and pandemic and seasonal pandemic and endemic. But I should say that malaria for us, our observation from our community engagement and accountability system is no longer seasonal. It became endemic. You get it every day, especially in big cities like Nairobi. And same as cholera, became more of an endemic issue that happening every day and not during rainy seasons. So we urge really people to put our hands together to support us. We are happy to work closely with all of you, to work closely with our national governments, Ministry of Health, to give you direct access to communities. But more importantly, if there is a need to work cross-border, we would be very happy to facilitate that and to make that happen through the branches and connections we have with governmental authorities. Once more, I really wanted to welcome you on behalf of the IFRC. Once more, I wanted to repeat our commitment. I wanted to thank my colleague Jason and Mercy and all of you who has been part to pull this unique gathering together. Thank you very much. Thank you.
Thank you, Mohammed. So I would like to invite Dr. Michael Charles to provide a welcome from the RBM Partnership to End Malaria.
Thank you very much, Jason, and good morning, ladies and gentlemen. I'm deeply honored and privileged to share a stage with my former boss, Mohammed. Thank you very much. It's great to be here to continue to amplify the work that we all are doing collectively. When I was asked to make a few remarks, I had to go back through memory lane in terms of my journey in malaria. And some of you would have heard this story, so apologies for that, but I think most of you will probably have not heard it from me. So allow me to reflect on my journey, which started about 25 years ago as a junior doctor in Lagos, Nigeria. As you know, Lagos is one of the most populated cities in Africa and in the world. And on that fateful day, I was in the clinic on call in the hospital. And this 9-month-old child was rushed to the hospital. His name was Sule. He had cerebral malaria. He was febrile, convulsing. The mother brought him in. The mother was a petty trader who couldn't afford medication or the medicines we wanted to give the child. So we had to scramble around from the doctors, nurses, get the medication, and we treated Sule. Sule went home 5 days later, and he was healthy. A few months later, about 4 months, Sule was rushed back to the hospital. Sule was malnourished, febrile, and unfortunately, Sule passed on in my hands. That was the first time I cried for a patient, not the last time, but the first time, because I felt I had failed Sule, the state had failed Sule, the world had failed Sule. Until today, we still have many Sules that we need to save. At that time was when the world came together and said, never again should we be losing a child every 30 seconds. Never again should we be having so many children dying of malaria. So the world came together, Global Fund, RBM, WHO, and we had mass campaigns in terms of supporting children, protecting them initially, and then we went to universal coverage. A lot of progress was made, and a lot of progress is still being made today. However, again, we've reached that crunch time, what we call the perfect storm. We have issues around biological threats, and we commend WHO in their last World Malaria Report in terms of the recommendation of the active ingredients dual nets, which has been rolled out in many countries. And again, thanking AMP for its extensive support, technical supports to countries, and ensuring that the priorities of countries are met. So the biological threats are real, but also we have the issues of climate change, more rains, and we heard it from Mohammed. And we have the statistics to back that up in Pakistan in 2022, where we had a 5-fold increase in malaria, or in Mozambique, or in Madagascar that was hit by cyclones 3 times in 1 month. Climate change is real, and the intersection with health is also real. And that's why we need to continue to be agile and to be flexible, and to also have what we call anticipatory action, where we're really anticipating what will come and able to prepare ourselves. Again, I commend AMP for all its support over the years on this. The third thing is the issue of funding, and we've seen that, again, funding is dwindling, and a lot of our countries are not able to meet all their needs. So they need to prioritize, they need to do stratification, and they need to do subnational tailoring. Certainly, this is not easy. I know this is on the agenda for the next few days, and it would be good for us to hear your experiences and how we can work better together on that. Allow me to just pick on 4 or 5 key pillars if we are to reduce the malaria burden globally. The first one is we need leadership commitments at country level, at regional level, at community level. I know a lot is happening in all our various countries, and we will continue to work with your leaders in terms of ensuring that malaria stays high on the agenda. The second thing, especially when we talk about dwindling funding, is that we need to ensure our surveillance systems are active and we have data for decision making. So as RBM partnership, we're definitely working on that, and we'll continue to support you within the countries in terms of just making sure we can gather the data for decision making. The third point is community engagement. If we're to reduce the burden of malaria, it starts in the communities and it ends in the communities. So we need to actively continue to work on community engagements, continue to ensure that there's ownership at community level for the people. The fourth aspect is we need to strengthen our health systems. And I think in high burden, high impact countries, malaria can really be the entry point in terms of strengthening these various health systems. So I think, again, how do we focus on that? And how do we ensure that our health systems are strengthened? The last 2 aspects is we need to build new partnerships. And this is where the multi-sectoral approach to ending malaria comes in. I was in a community recently speaking to community members about malaria. And one lady said, what use is it if you save my child from dying of malaria, but he or she dies of pneumonia the next day? So we really need to work together across board, across sectors, to ensure that we are driving down the burden of malaria, and we can bring more partners in terms of funding. 2 more things. The RBM partnership, we have a website that you can please access on our website. It's www.endmalaria.org. It has many tools on it that really complement some of the AMP tools and guidelines that are existing. So I encourage you to please look into that. I will end on a quote, but before I do that, I want to recognize 3 people that have been instrumental in my journey and in me being here. And I'll embarrass them by asking them to stand for you to give them a loud ovation. The first person is Mohammed, Jason, and Marcy. Without their relentless support, I wouldn't be here. So really, thank you so much. Allow me to end on a quote which I came up with this morning, and it states, by embracing innovation, embracing collaboration, embracing compassion and determination, we can have more countries eliminating malaria, thereby turning the tide of suffering into a legacy of health and resilience for humanity. Let us all come together to ensure we can turn the tide of suffering into a legacy of health and resilience for humanity. I thank you.
Thank you very much, Michael. I just wanted to check, has Dr. Lanaya from the Ministry of Health Kenya arrived? No, okay. So look, we'll move then to our first presentation, which is a video presentation. And it is a presentation on the global scale-up of ITNs in the 2000 and applicable lessons learned for the current and future context. And the video has been recorded by Cordelia Kenny. So if we can put that video up.
Hello, thank you for being here today, and thank you to the organizers of this conference. I'm excited to share this work with you and to dive into this topic. So my name is Cordelia Kenny, and I'm going to be talking about a project that I've been working on with the Urban Institute and Open Philanthropy on the global scale-up of bed-nets in the 2000s. So to start, I wanted to begin with this lovely curve showing the cumulative global ITN distribution over time and really focus on this period of 2004 to 2014, because this is when we start to see scale up really starting to take off. So the question of the case study was really, how did this happen? How did we get here? And in this talk, I'll also be talking about some lessons we might take from the scale-up experience in the 2000s to apply to current and future vector control efforts in malaria. So to set the scene and just orient ourselves, these will be the 5 sort of key sections I'll be walking through. Just want to put that up there. And to start, just to very briefly look at some of the foundations of going to scale for ITNs. So I'm sure this is history that many of you in this room are very familiar with, so I won't spend too long here, but just to note that insecticide had been added to nets as early as 1950s in China, so there's a long history of using ITNs for malaria prevention. In the 80s, we start to see some clinical trials, and then in the 90s where we see RCTs specifically looking at child mortality reduction. So we have the first one in the Gambia showing amazing results, but we had questions of generalizability, so that's why we then have these 4 RCTs in the 90s. By 1998, we have our first Cochrane review, which shows great reduction in mortality, not just malaria, but all-cause and child mortality. We have these study updated in 2004 and 2018, and the results do hold up. So really, the basic point here is that by 2000, going into the 2000s, we have very robust evidence that nets are effective and a great tool in the malaria toolkit. So to answer the question at the bottom of this slide, was it a breeze? Of course, it was not. It was very much informed by or prevented by a lack of funding. So the commitments that were made and the robust evidence was not enough. So in response to deal with this funding shortfall, there were 2 main scale-up strategies that were adopted. The first was to socially market nets and to sell subsidized nets to those who were most vulnerable and couldn't afford commercial prices. And this was really the only approach that donors wanted to do early on. The second strategy that emerged was to mass distribute nets for free through integrated national campaigns. And the basic idea here was that, we have this life-saving tool, hundreds of thousands of people dying from a preventable cause, so let's treat nets like vaccines, like a public good, and fund and distribute them as such. So in the interest of time, I'm going to be skipping over social marketing, but I do want to say that the case study was not really going into pro or con anything. It was how did scale up happen? And so with informing the integrated campaigns approach was the reality that social marketing was not achieving scale. So poverty and net costs were the biggest barrier to use, and coverage was really low in the 2000s. So even highly subsidized nets were too expensive. So integrated campaigns, by contrast, bundled interventions that were targeted for child survival, which included things like measles vaccinations, distributing deworming pills, and the main actors who were doing this in the early 2000s were the IFRC, other nationally affiliated Red Crosses, CETA, and the US CDC. And integration, of course, had its own challenges because it was coordinating with a lot of different partners with a lot of different ways of working, so it took time. But let's look at the evidence from these campaigns. So the first one in Ghana in 2002 showed proof of concept, and then we have proof of scale with Zambia in 2003 and Togo in 2004. And we can see we have remarkable increases in net ownership, so really fantastic results. And no one else was really funding these campaigns at the time. It was really the IFRC and CETA. And an important decision that they made as well was to hire anthropologists to try to understand barriers to net use, user preferences, and this was a very important thing to make sure that, you know, net use was happening as intended. And of course, this is still an open conversation and question of around net use and net access. And here I just really want to underscore the importance of partnership. So to use Zambia as an example, this 6-day campaign involved 18 different partners to implement. So really, really important role of partnerships in the scale-up story. And this evidence was very important for policy and financing. In fact, the Global Fund decided to approve its first grant for a mass distribution campaign in Niger in 2005, directly in response to the evidence from Zambia and Togo, as well as from advocacy from the Red Cross. And then for the WHO cited evidence from a series of campaigns in Kenya, the results of which were published in 2007, as informing its policy recommendation, also in 2007, to recommend integrated mass delivery. And we can see here the integrated campaign approach really did achieve a much greater ITN coverage compared to other forms of distribution at the time. The US government as well switched from social marketing through USAID to integrated mass delivery through the PMI. So all of these pieces were very important for beginning to signal the existence of a market for nets in the 2000s. And that's all very exciting. But again, to emphasize that funding or the lack thereof was far and away the biggest constraint to scale up in the 2000s. So in addition to the very real constraint of not having funding, there were other things at play too. And just to very briefly touch on some of them, going into the 21st century, there was a global debt crisis, there was a recession, there was a preference among donors as well as governments for cost sharing, and there was also some institutional resistance to eliminate those cost sharing requirements. And really the basic point here is that because of these and other factors, there was a lot of debate about what would be the most effective, optimal scale-up strategy. And the WHO in its 2007 press release actually cited this inability to reach a consensus as a delay in the ability to go to scale with nets. And looking at the funding over time, we can see how much the picture really has changed since 2000. So we have hardly any malaria funding to speak of comparatively in the early 2000s, and really limited to no donor funding. And it isn't until later on in the decade where we really start to see a lot more funding. And we can see too that this is after the establishment of RBM in 1998, after the Abuja Declaration in 2000, after the Global Fund is established, after PMI is established. So funding itself also took time to scale, and we can also see that commitments are not enough. There has to be action and funding that's backing that. So let's zoom in to the Global Fund in particular, a very important actor in the story. So by 2010, the Global Fund was providing 70% of all global malaria funding, and currently it's around 65%, so still very significant. And with the emergence of the Global Fund, it really changed the terms of debate around what is the best delivery model for ITNs, because again, lack of funding was such a huge constraint. And to keep in mind too that the Global Fund was conceived of as an emergency response to HIV/AIDS specifically. So the inclusion of malaria was definitely not guaranteed, and it was very much thanks to the advocacy of malaria advocates, of RBM, of the African Union, of African heads of state, that malaria was included in the Global Fund. And to go back to the previous slide and looking at when we start to see this much sharper increase in funding in 2007, 2008. An important piece of that was the creation of the Harmonization Working Group. And what this did was respond to the reality that malaria grants weren't being approved at very high rates at the Global Fund, and the Harmonization Working Group provided technical assistance to countries to in the application development process. And this more than doubled the approval rate between 1 year. So again, really underscoring the importance and centrality of partnership and working together across different partners in the Scale Up story. And the last point on the Global Fund I want to make is just that, you know, like many other aspects of Scale Up, it wasn't a seamless, perfect story journey. There were definitely bumps along the way. Namely, in this case, procurement challenges and procurement delays that prevented products from getting out the door. But as alluded to, and to really just emphasize this point, Scale Up was really greatly enabled by coordination between partners and paying attention to different partners' needs. So it wasn't just mobilizing the funding, which of course was important, but also learning to work together and working together effectively. And to just get a little more specific, here are, you know, a smattering of some of the really important actors. It was all of these different actors working together. And in the words of an expert who I spoke with for this project, she said, you know, it really was the spirit of partnership and all hands on deck that really made the difference. So it was those advocating for the money, those supporting countries to get proposals right and campaigns done on time, coordinating with net manufacturers, as well as researchers monitoring the situation. And just to note too that malaria doesn't have a lot of advocates, so moving forward, this sustained collective action and coordination will be even more important. I'm going to just touch on this briefly, but it's definitely an important piece of the story, manufacturing capacity and market signaling. So what I want to emphasize here is the importance of innovation and the relationship between innovation, unit cost of nets, and market signaling. So this was very much getting worked out in the 2000s, going into the 2010s, and still getting worked out, especially as new tools, new nets are coming online. But there was definitely a nuanced relationship between volumes, between assuring a market so that more manufacturers and existing manufacturers felt comfortable to scale their production, lowering the unit costs so it was easier to get the numbers up, to get the coverage up. And this is where, of course, the Global Fund and PMI were important because they were helping to procure those very large volumes. And the regulatory environment, also worth mentioning because that influenced, of course, the pace at which new manufacturers were entering the market. And the key takeaway here is that the regulatory environment, unit costs, the need for innovation, these are still very much live topics. So there is definitely things to be learned from the experience of the 2000s. So on that note, what are some lessons we might take away from scale-up efforts in the 2000s? So let's first look at what enabled scale-up. So I touched on some of these factors, but the bigger picture here is that it wasn't just one single factor. It was all of these factors coming together, and many of these are still relevant today. So some of the ones that we touched on were funding, collective action, the importance of evidence, as well as technical and policy guidance. But of course, there were constraints too. And again, many of these might still be relevant today, including funding, operational and logistical challenges. These are still live issues. And if we compare the early 2000s with 2024, how different is the context? So we have, again, increasing resistance and waning effectiveness of antimalarials, though we do have a better prevention toolkit. We have complex interconnected global crises. We have emerging pathogens. And so really the point is that the warning signs are kind of all there, and we're seeing some of the same challenges that we were seeing 20 years ago. So there definitely is a need to reflect on and remember some of the lessons learned over the past 2 years of experience, or 20 years of experience. So I think there are 3 high-level lessons that we can take away from malaria now. The first is that, high-level commitments from policymakers and robust evidence was really important, but it clearly wasn't enough. So to actually ensure that rhetoric was backed with action, malaria needed then and needs now sustained coordinated advocacy and political will. And also related is the importance of partnership, which I really don't think can be overstated in this story. That coordinated partnership was absolutely essential for being able to go to scale. And finally, it's very important to be clear-eyed about what the barriers are, but also to always keep in mind and be striving for what the ultimate goal is, which in this case is eliminating malaria and being a little idealistic. So it has to be both. And to think of 2 specific priorities that I think also emerged in this case study. The first is on strategy. So definitely nuances needed in delivery strategy now and in the future, and especially as new tools are developed and deployed. So this also includes remembering that bed nets are by no means the end-all be-all for vector control. There are many other aspects of vector control for malaria that are very important, including broader socioeconomic development. And context is very important because we are not reaching all populations, all people who need nets. And there are lots of different factors that influence net use behavior with nets that we need to understand and pay attention to, especially now in a context of more humanitarian crises and in a global conflict. And second, critique that came up from the scale-up efforts of the 2000s was that research was sidelined. So there will always be a need for research and development into new tools across the entire toolkit. So really, research will always need to be prioritized. And of course, that requires funding, and funding remains a challenge. So we can see that the funding gap as of 2022 was 56%, where don't have guarantees with bilateral and multilateral funding. And so some of the very same questions around balancing the need to increase coverage with sustaining long-term delivery systems are coming back up again. We're dealing with the same questions. And so that's why the role of social marketing there may be a role now, as well as segmented markets, depending on the context. So I definitely encourage you to read the full case study. It goes into a lot more exhaustive detail, but it's available on the Urban Institute's website. I'm happy to keep the conversation going as well. Please feel free to reach out. Thank you so much for listening, and I hope you have a great rest of the meeting.
Good. So I'd like to invite our next presenters, Cedric Mingat from Results in Health and Mshenge Madinga from CHAI, who will present on 3 billion nets and 20 years of mass campaigns, procurement trends, and forecasting the next 5 years.
Good morning, everybody.
So we're just having some technical problems with this computer, where I think he can help us. Let's see.
Okay, problem solved. Good morning, everybody. It's nice to see all of you. My name is Cedric Mingat. I work for Results in Health in the Netherlands, and I'm co-chair of the Net Mapping Project with John Milliner, who unfortunately is not able to be here today, and he sends his regard. I will cover half of the presentation. We're looking back on how we got here, and Menashe will take us forward into the future with some forecasting. And I really want to thank AMP for talking about logistics in the first morning of the presentation. Sorry. I think it's really important to put things in perspective and talk about the sheer size and scale of what we've done and how we got here. Okay, so this is 3.1 billion mosquito nets in 20 years. More or less, I think I calculated in my head, it's over 100,000 40-foot container that have been manufactured and shipped over the last 20 years. Last year also marked the 20th year of the net mapping project, so we've been tracking those nets since 2004. Quick overview on the net mapping project. So we receive quarterly information from ITN manufacturers. We produce quarterly reports, which are posted on the website. We segregate ITNs by country, by net type, by donor, and by region. Please access our website. We also include maps on it where you see where those nets are going. And when the data is available, we have in-country distribution plan for maps. Again, this is not distributed nets, this is shipping data from the manufacturers. Big thank you to all of the manufacturers. We could not be here without the private sector, without the Ministry of Health and all of the partners. Currently, there are 13 manufacturers who provide ITN data to the net mapping project. And this is their headquarters in 9 different countries. So thank you very much, manufacturers. Okay, a little bit of data. On the left is the cumulative numbers of net shipped, starting in 2004 with 5 million nets, ending in 2023 with 220 million nets, or 3.1 billion total. More or less a couple of trends. We can see that since 2017, we've been more or less steady at around 200 million nets a year. Menashe will tell us if that will increase or not into the future. And the majority of those nets, 87%, is going to sub-Saharan Africa. We all were in Geneva in 2020 to celebrate 2 billion nets. It took 10 years to reach 1 billion, 5 years to reach 2 billion, and then 4 years to reach 3 billion, right? And the bottom graph shows the exponential increase of ITN shipped. These are 5-year intervals. Okay, we're going to look a little bit at the type of nets. The top lines look at the breakdown between standard PBOs and dual AI nets. You can see that until 2017, we had 100% standard nets. Starting in 2018, we had a few PBOs. And in 2019, we had a few dual AIs. And then you can see the transition over time. Last year, we shipped more than 50% PBOs and 18% dual AIs. So quite a large increase. And the 2 bottom graphs show who is funding most of these nets. So this is data since 2009. So annually, it fluctuates quite a bit. But since 2009, slightly over 50% of the ITNs have been funded by the Global Fund. And then you can see the rest of the main donors here. Okay, and I'll take a minute to look at the next generation of nets. The top line is looking at PBOs. So since 2018, we've shipped about 400 million PBOs to date. Unsurprisingly, the top recipients are Nigeria and DR Congo, which are over 1/3 of all PBOs that have been manufactured. And the top 5 countries make up half of all PBOs shipped. And then the bottom data looks at dual AIs. Since 2018, we've shipped about 100 million mosquito nets. and the country distribution, unsurprisingly, is similar to PBOs. There's a few slides that disappeared, but this is most of my presentation. We want to say a big thank you to AMP for hosting the net mapping project. Huge thank you to the UN Foundation for funding us. And finally, to all of the ITN manufacturers for sharing their data. Thank you so much.
Good, so we can open up now for questions. Did you have addition? Oh, sorry. Sorry about that. You're gonna do.
Good morning to you all. My name is Munashe Madinga. I'm a senior regional manager for Vector Control, and I'm going to present the next couple of slides on behalf of the Global Malaria Commodities Forecasting Project. So, as we mark the point where 3 billion bed nets have been distributed, a question comes to mind to say, what does the future have in store for us in the bed net space? And to help to answer this question, in 2021, CHAIA assembled a consortium of partners to develop a more organized approach to navigate an increasingly complex malaria commodities market. And the objectives are to improve visibility and consensus, as well as to highlight existing commodity demand and potential gaps in the commodities coverage, identify factors influencing global uptake of key commodities, and highlight the opportunities for additional investments. And through this consortium, 3 annual outputs are produced. The first one being a short-term procurement forecast, which covers a period of 3 years, followed by a long-term need and demand forecast, which covers a decade, and then a deep dive analysis on specific commodity markets. And these methods really rely on historic trend and regular expert opinion. And the link there takes you to the dashboard that has those outputs. So it has taken us 20 years to reach the 3 billion nets. We expect to reach the next 3 billion in half that amount of time. And when we think about the numbers seem big, but however, this reflects only a small annual increase over the next decade. And the modeling output that you see at the right hand of the slide is a modeling of that future decade, and 3 budget scenarios were used. The first one being that there is a reduction, a 15% reduction in the malaria budgets, followed by another scenario where there's a minimal increase in the malaria budget, and lastly, where there is an expected 2% annual increase in the malaria budgets. And what the modeling output showed us is that there is a gap of 62 million nets between the funding scenarios by the year 2032. And then when we look at the short-term forecasts, we see that they are heavily influenced by ITN coverage and budget limitations. When it comes to ITN coverage, most countries are faced with the choice of whether to go for universal coverage, which means procuring an adequate amount of nets to cover the entire population, or to use the subnational tailoring approach, where you procure the number of nets that will cover the most at-risk populations. And for our modeling, we used the assumption that the population where the prevalence of malaria is greater than 5%. And for this modeling output, for the short-term forecast, we used 4 scenarios, which were modeled across the two coverages, universal coverage, as well as the subnational tailoring. And then when we compared the outputs of these modeling scenarios, we saw that the scenario with subnational tailoring and a minimal budget increase was the one that reflected the most or was similar to the shipment data that was shared for 2023. And then when we then move to the long-term forecast, we see that available budgets for ITN procurement really determine the rate of switch to dual AI nets and influence the level of ITN coverage that is attainable. And for this modeling, we modeled across 3 different scenarios and assumed subnational tailoring across all 3 scenarios. And for these budget scenarios, again, we have where there is a minimal increase in the budget, a 2% annual increase in the malaria budget, and a 15% decrease. And here we see that under a reduced budgeting scenario, we anticipate countries to heavily target net distribution, thus reducing the global volumes, and this can potentially result in coverage gaps. We also see that in situations where there is an increase in the malaria budget or adequate resources, there are higher net volumes that are procured by the countries, as well as an increase in the uptake of the dual AI nets. And the reverse is true, where when countries have a limited budget, there are lower net volumes, as well as lower uptake of the dual AI nets. And this is just to share that as we were doing this modeling, there are a few caveats and considerations to keep in mind. And one of them being that the forecasts that we have done do not yet account for any new tools that are coming into the market. And also that at the time that we were doing the modeling for these forecasts, this was before the latest pricing agreement from Global Fund on dual AI nets. So the price differential between the dual AI nets and the PBO nets was still very significant. And then I would like to thank partners of the consortium, and also like to direct any questions or comments to the email address above. I thank you.
Good. So colleagues, now we can open for questions. So we'll just take questions from the room. Any? Yes. Professor Ma?
Oui, Dr. Khalil Keita de la Guinée.
Can you just introduce yourself when you ask your question? So were there 2 questions? Maybe Professor Ma, why don't you go first? Just introduce yourself and then ask your question. It should be the blue or the green button.
No, thank you. This is Dr. Maha. I'm representing Pakistan, and thank you for the nice presentation. I just have a comment, sort of a question, which is regarding for the previous presentation regarding identification and finding other donors apart from the existing donors, because right now everybody is talking about gap. And these type of meetings are very good forum where we can invite other donors such as UAE, and we can present our task, our work, where we can find out other donors to help to reduce that gap.
Good, thank you. I think there's another question in the room, and just so Cordelia had recorded that one. We won't be able to ask her questions in her presentation. We certainly take comments, but any questions for the 2 presenters here on the stage? So maybe we'll go to take the 2. We'll first start with you and then we'll go to Dan. So go ahead. It's the green button, just at the bottom of your mic. Yeah.
Okay, I'm Alexis from West Cameroon. My question goes to Chai. It looks like you are admitting that by now the result you presented may be outdated already because you didn't take into consideration the new tools coming, like the vaccines, for example, or the changes in prices. So when next are you going to update your forecast to take into consideration these aspects? Thank you.
Good. Daniel?
Good morning, Dr. Dan Perlman from Rotarians Against Malaria Global. I'm interested to know if there's any good studies that show a reduction in malaria of PBO nets versus dual nets.
Good. So Daniel, if you could close your microphone and then we'll hand over to the responses.
J'ai demandé à parler, à poser mes questions. OK. OK. Merci pour l'organisation de cette importante rencontre. Je fais remarquer déjà que pendant la présentation, les autres pays ont été cités. La Guinée n'a pas été citée et nous sommes bien dans la salle. Ça, c'est ma première remarque. Deuxièmement, je voudrais aussi dire que il y a eu d'importants efforts qui ont été fournis dans le domaine de la lutte contre le paludisme, notamment dans mon pays. Alors, ce qui a permis de réduire le taux de prévalence de 44% à 15%. Merci pour les efforts. Alors, parmi ces efforts, nous avons vu que dans le cadre de la distribution des moustiquaires, nous avons bénéficié de certains apports. Vous avez dit tout à l'heure que le Fonds mondial intervient à hauteur de 64%. Il y a PMI aussi qui intervient. Mais pour nous, il faut louer les efforts en plus de tous ces apports-là, il faut louer les efforts de l'AMF qui nous a secourus pendant les 2 dernières campagnes, c'est-à-dire en 2019 et en 2022. Donc, le gap de moustiquaires dont on avait besoin, a été couvert, comblé par l'AMF. Et cette année, nous comptons encore organiser, c'est-à-dire en 2025, une campagne pour tout le pays. Alors, nous avons un gap important de moustiquaires et nous aimerions voir aussi l'AMF combler ce gap-là, en plus de ce que les autres partenaires, le Fonds mondial et PMI, vont donner. Alors, ma question maintenant, ça c'était une intervention sur mes remarques. Alors, ma question maintenant, est-ce qu'on est en train d'envisager actuellement, parce que l'Afrique est en train de connaître une certaine menace d'un vecteur invasif qu'on appelle Anopheles stephensi. Et l'Anopheles stephensi, disons, provoque la transmission du paludisme tout au long de l'année. Si l'Anopheles gambier, que sais-je encore, funestus, ont une transmission, peuvent faire une transmission saisonnière, c'est-à-dire en début de saison des pluies, mais stephensi est en train de progresser vers l'Afrique occidentale. Donc, en plus des pays de la Corne de l'Afrique, Djibouti, Soudan, Éthiopie et autres, c'est venu en Afrique occidentale, c'est arrivé au Nigeria et au Ghana. Donc, nous, on n'est pas loin. On est en train de mettre en place un mécanisme, la surveillance en faveur de cette maladie-là, de ce vecteur-là. Donc, voilà l'information. Est-ce que derrière, on est en train d'envisager aussi que si d'aventure ce vecteur-là se répandait un peu partout dans nos pays, quels sont les outils qu'il faut utiliser pour circonscrire ce vecteur? Je vous remercie.
Merci beaucoup. If I can just ask people in the room, if you can get the microphone a bit closer to your mouth so we can hear you clearly. So we'll hand over for responses. Okay, we have one final question. We're just running a bit short on time. So one final question.
Hello, everybody. Sid Rupani from the Global Fund Supply Chain Team. It's a comment about the volume of the dual AI nets projected. So from conversations with our sourcing and PPTM colleagues, the dual AI nets volume the scale up will be much faster than projected, primarily because of the pricing agreed with the suppliers being better than was initially thought. So already in grant cycle 7, more than half the nets are expected to be dual AI nets. Thank you.
Thank you very much. So we'll close for questions and then we'll hand over to Cedric and Manisha for answers.
All right, thank you. I'll begin with the questions from this end. In the forecasts and the modeling, we did not include the new tools, primarily because of the limited evidence and data around them. But however, as more evidence and data comes up, these will be included. And we produce these forecasts every year. And the next short-term forecast is due in April. And then for the long-term one, it's due in September as well. So whenever we have the right amount of evidence and data, it will be incorporated. And then for the second question, I would say we would really leave that to the researchers to share that evidence of the head-to-head between the dual AIs and the PBOs. But for us, we are awaiting a lot of the research results on the impact of the dual AI nets.
Anything else then, Cedric, anything more to add? No?
Sorry, I think it's okay, sorry. Yeah, just quickly, thank you, Sid. Well noted for GC7, more than 50% dual AI. The net mapping project data will start reflecting that fairly soon. For the Rotarian question, there's quite a few of data now that shows the efficacies of PBOs and dual AI versus standard nets. So there's quite a few colleagues in the room that can probably provide you with those studies, but they are available. I think that's all the questions for now. Thanks so much.
Thank you very much. If we could give our presenters a round of applause. Good. And before we break for coffee, I would like to invite Dr. Charles and Dr. Erskine up to the stage, and they're going to recognize early efforts of Ministries of Health and partners.
Good morning once again. Could I please call on the delegations from Ghana, Zambia, and Togo to please come up to the stage? Delegations from Zambia, Togo, and Ghana. Thank you. That's Ghana coming, Togo, Zambia. Zambia here? Awesome. Zambia here? Oh, okay. Great, thank you. Thank you. So it's again a privilege to be here to recognize the fantastic efforts that has taken place over 20 years ago, and maybe again to go down memory lane in terms of, what got us here. In 2001, the Measles Initiative was set up, and this was really driven by WHO, UNICEF, USCDC, amongst others. To again drive the cases of measles down. I think in terms of what we've been preaching in terms of integration, our colleagues from the IFRC, from the Canadian Red Cross, USCDC as well, approached the measles initiative and said, how could we potentially piggyback on the great work that the measles initiative is doing in terms of really making sure that the campaigns can be integrated as much as possible. I think this translated into concrete action in Ghana in 2002, when for the first time there was an integration of mass distribution of nets with the measles campaign to under 5 children. This was in one district in the north of Ghana, and 15,000 bed nets were distributed. This was really a success that was again replicated in Zambia a year later, where 75,000 nets were distributed in 4 districts to under 5, again integrating that with measles. I think with the evidence from these 2 distributions, some of our donors and partners were quite impressed, and specifically the Canadian International Development Agency, CIDA, now called DFATD, really put a lot of resources into this. And in 2004, for the first time, we had a nationwide bed nets distribution that was integrated into a polio campaign, measles campaign, and deworming campaign as well. And over 900,000 bed nets were distributed to under 5 children in Togo nationwide. I think we've come a long way since then, and we've heard it this morning in terms of the amount of nets that has been distributed since then, which is over 3 billion. But really, this is an opportunity to recognize the early efforts of our colleagues from these 3 countries. And I'll hand over to Marcy to recognize them. But before then, also just to thank all the partners that are too many to mention, but you were all instrumental into the success of our early days. So thank you very much for that. And over to you, Marcy.
Good, so congratulations once again. We will break now for coffee, which is just outside this room, and we'll return here and start for our first session of day 1 at 10:35. So coffee break until 10:35. Thank you, everyone. I could just ask people to take their seats. We're going to start our first session in 1 minute. So if I just ask people to take their seats. Good. So thank you, everyone, for taking your seats. And we are going to start our next session, which will run us to the very end of the day. And the session is titled Stratification, Subnational Tailoring and Prioritization, Optimization of Vector Control in the Context of Limited Resources. And I'm going to hand over to Dr. Victor Alengana, who is with the WHO Regional Office in Africa, who's going to actually moderate for the totality of the day, Victor. So if you need tea, you need coffee, you just flag me and I'll come on over. So Victor, over to you.
Thank you very much. Welcome. Please settle down. We want to start a very interesting session on subnational tailoring. My name is Dr. Victor Alengana. I'm based at WHO Regional Office. And I've met most of you when we've done SNTs online or when we've done stratification workshop. I've interacted with some of you. And this session has 2 components. One is it's always good for us to remind ourselves what are the basic principles of S&T, what are the ethos, what are the guidance around it. And then the second part is really learning the lessons learned and best practices and how we can actually use or tailor S&T in our countries. So we start off from our presentation from my colleague, Bea. I think most of you know Beatrice, but she's going to introduce herself, and then we take questions after the session. Bea, over to you. Thank you.
Thank you, Victor. Hi, everyone. First of all, apologies for my voice. I have a slight cold. Hopefully it's okay in terms of voice. So hi, everyone. My name is Beatriz Galatas. I am an epidemiologist and I work at the Global Malaria Program under the Strategic Information and Response Unit. So I am the focal point in GMP for the S&T work, subnational tailoring of malaria interventions work. And I'll be giving you a brief overview of what we envision the S&T work is at WHO and some examples of how this has been done by countries. So I see somebody's taking care of my slides, so thank you. Next slide, please. Somebody's asking me which language I'm speaking. Let me just say English. Okay. So what is subnational tailoring of malaria interventions? Essentially, S&T is the use of local data to make decisions, usually to inform on the most appropriate mix of interventions at a specific unit or area for optimum impact, whether that's at strategic level or the prioritization level. Next, one more click, please. Countries face several decisions throughout their national strategic cycle process. Those decisions can start with the national strategic plan development, where countries ask themselves, where should we intervene, with what interventions at more strategic level. Afterwards, countries face the question of, face the situation of applying for funding or reviewing the funding available, preparing their budgets, and at that level, the question becomes, what interventions can we actually afford and what should be prioritized considering the strategic plan we started with. And then during the implementation process, countries also face questions such as, when should we intervene in terms of timing, what type of strategy would be the most appropriate, etc. So the idea is that countries use evidence to make their decisions, all of these decisions, as much as possible. Next slide, please. And this is not new. In fact, the use of data to make decisions is anchored on basic principles for good health. Health policies should be informed to, as best as possible, by the evidence derived locally. And this is also considered within the global technical strategy of malaria as one of the main pillars, and as well as one of the pillars of the high burden to high impact approach that WHO launched a few years ago to make sure that the high burden countries get back on track. Next slide, please. So I will walk you through the process, the standard process that WHO recommends countries that wish to use the S&T process to make decisions. So I'll walk through the steps one by one by now. The one thing I would like to mention here is that to the most extent possible, this process should be as holistic and as all-inclusive process as possible. It should be, of course, led by the MOH and NMCP, and it should be as much as possible also ingrained within the wider health sector planning. Next slide, please. So I'll start one step per step. So let's say at any given country, a new national strategic plan is going to be started. And the NMCP and the MOH would like to use the evidence available to them to start making all of their decisions throughout this life cycle. So the first step that we recommend is that countries establish a very strong S&T team. Essentially, this team should be led by the NMCP and the MOH partners, but should also include all of the relevant stakeholders that are important in the decision-making process, not just the analytical or the implementation partners, but also those who are funding the interventions. As being part of the process, make sure that everyone is aligned under the same decisions and the same plan. And essentially, this team is responsible for following up the process from beginning to end, including identifying the data needs, who has them, make sure that the analysis is appropriate, developing the strategy, developing the mobilization, the resource mobilization plan, prioritizing, etc. Next slide, please. So at the beginning of the strategic plan development process, countries list all of the interventions that they would like to include in the strategic plan. The next step is to, for each intervention, identify what are the criteria or the characteristics that would be required in order for a specific intervention to be deployed in a specific area. And these characteristics or these criteria are based on the WHO standard recommendations per intervention, but they should also be adapted to the country context. So what you can see from this table is that for each intervention, you have a series of criteria that apply. Of course, transmission is the underpinning criteria that nearly all interventions use in order to identify where they should be located. However, countries may and should actually review other additional contextual factors, determinants of malaria transmission that are really important to identify where interventions are most appropriate. And those are all of the criteria that you can see as columns in the table. Now, once this process has been fully discussed with the entire S&T team, the next step, next slide, please, is to transform these criteria into appropriate maps at the appropriate unit of analysis. That's the district, the health catchment area, whatever it is that the country is deciding on. Now, what you can see here is the example of Togo, where the transmission maps were prepared. You can see incidence and mortality. There's also a series of other maps that were prepared in order to make decisions. Those include aspects like geographic access to healthcare, treatment-seeking behavior, quality of care indicators, coverage and history of past interventions, entomological indicators, pyrethroid resistance metrics, coverage of specific indicators, or seasonality. So as you can see, all of these layers of information, once prepared and validated each one by one by the S&T team, are then used to make decisions. So next slide, please. So we come back to the table of the interventions and the criteria, and per intervention, we identify the specific maps or the specific indicators that will help target or tailor that specific intervention. So I'll give you here the example of SMC, where aside of incidence, we also looked at the historical implementation of SMC, seasonality, rainfall patterns, age distribution of burden patterns, and we arrived to the map that you can see on the right, which identified the areas eligible for SMC as per the strategic plan. Next slide, please. When you do that throughout the table for all of the interventions with their specific criteria and their specific stratified indicators, you end up with a map like this, or a series of maps like this, where each intervention has a specific location where it should be implemented strategically. And that, if you put it together, ends up with a mix of interventions map, which you can see on the right. In reality, usually it's not just one map that comes out. Countries go through through different scenarios, different questions, and a series of scenarios may arise. So one of the ways to compare these scenarios and make a decision on which one is the most appropriate one is to actually compare them in terms of the impact, future impact, among others, other metrics. Next slide, please. So currently, the best option for us to project impact into the future is through mathematical models. So at this stage, countries work with mathematical modelers who have the capacity to calibrate specific mathematical model, dynamic transmission mathematical models to the specific context of the country so that they can provide the most accurate impact projections into the future. What you can see here is the example of a series of scenarios that were reviewed in Togo, where you can see impact varying from the business as usual or the previous plan to different plans that were reviewed. So after this evidence is available, there's a decision that is made. Of course, it's not just based on this discussion. There's there's an overall discussion that needs to happen, but at the end of the process, next slide, please. An NSP is finalized with a mix of interventions and it's costed. So it is at this point when the costed strategic plan has to be compared to the resources that are available to the country at that specific moment. You all know that this usually aligns with the global fund cycles, big funding cycles, PMI cycles, etc. But at a specific point in time, there needs to be an assessment of the resource gap and the resources that are available. So at this point, S&T has two purposes. It can help prioritize the investments or the resources that are available, but it can also help as a tool to mobilize additional resources and fill in the resource gap. So I'll cover the most common one, which is the prioritization step. Next slide, please. And again, when countries are prioritizing, they have to start with a strategic plan. So we come back to the drawing board, to that table with the list of interventions that were included in the strategic plan and the characteristics that should be there per or should areas should have in order to have those specific interventions. And from there needs to be a further stratification process so that we're prioritizing the areas that really would need or benefit the most from each of these interventions. This is the most complicated part of the process, the most challenging. Usually it involves dropping some interventions that may be too costly, such as IRS, for example. It may also involve further tightening or filtering the criteria for specific interventions, such as NETS or SMC, etc. So next slide, please. I will show you, because I think in this particular audience is of interest to look at what the prioritization looks like for ITNs, mass campaigns. Unfortunately, several countries have or are in the process of making this decision right now. Resources are scarce, and countries are needing to make the decision of whether to scale back specific mass campaigns from specific areas. So I'll give you the example, very brief example of what happened in DRC. A discussion was held after a situation of a resource gap was identified. In this situation, the NMCP and its partners identified a series of criteria, which I show here. I won't get into it because I don't have time, but just to portray that there's a discussion that is held where all of the characteristics of the areas that should receive or should prioritize ITNs are listed. That includes transmission, includes or excludes urbanization areas, and additional aspects such as receptivity, limited access to care, conflict, the raising resistance of ACTs, etc. So next slide, please. After a ranking of these criteria and preparing all of the maps that were required, the country ends up with a plan like this, where districts or health districts are categorized as per their priority, from the highest priority, 1A, to the lowest priority, which is 5, and then the number of health zones are counted. This is then translated, next slide, into a costed plan. And knowing that there's a specific costing gap or costing limitation, we know that starting with priority 1 or 2 would still get us to the resources that are available, but in DRC, covering what they called 2A was already surpassing the available resources. So at this stage, mathematical modeling came in, next slide please, where the areas in 2A specifically were ranked according to impact. So you can see that for the prioritization process, the mathematical modeling came at the end of the process once a specific set of areas with the same characteristics were identified as needed further prioritization. And at that step, mathematical modeling became important, but there was a very, very relevant and key previous part of the process based fully on local level discussions and stratification in order to make a final decision, which the country made. Next slide, please. Another quick or easier approach to prioritization is the concept of deprioritizing or micro prioritizing urban areas through the micro stratification of these areas. There's a few reasons why urban areas differ from rural areas because of their transmission determinants, because of the focality of the transmission, because of the population dynamics, the private versus public health sector coverage, etc. So there's a few reasons for which urban areas should be looked at differently, and there are, in a way, the easiest approach that countries may have to scale back ITNs without causing major impact or resurgences. So you will have a session this afternoon where a few speakers will discuss the global framework for urban area responses, malaria response, as well as some examples of how countries have gone about doing this. So I won't get into the details, but it is one of the options that's available when deciding where to scale back ITNs as well as other interventions of malaria. Next slide, please. So at the end of the process, prioritization decisions are made, the budgets are finished, and the actual plan begins. And S&T does not stop there. So as I said, during the entire implementation process, it is important to continue to constantly learn, collect the information, and review the information to increase effectiveness. Because the idea, excuse me, is to ensure that we get to maximum impact. Therefore, reviewing indicators of all of the interventions that are implemented throughout the life cycle of a strategic plan in order to improve their impact through the improvements of effectiveness or the other strategies that are delivery strategies that are being used is key. And at that stage, it requires constant data collection, review, and decision-making. Next slide, please. So as you can see, the process that I just outlined ensures or has an ethos and a series of principles, which in summary include the fact that this process, if done in this way, ensures ownership from the program and the MOH. It ensures that to extent possible, it is informed by evidence. Of course, other factors also come into play throughout the discussions, but the local data is used. It ensures that there's alignment and harmonization across implementing partners, donors, etc., so that the investments are done on the results and everyone is accountable for the results that are observed because everybody was part of the process to begin with. Throughout the process, of course, different countries will review or reveal different capacity in order to actually implement the process on their own or with different levels of support. So it is really important that as countries and as donors engage in the S&T process, there's constant discussion on how to ensure sustainable capacity development in the country. So next slide. Thank you very much. Yes, thank you very much. I would like to thank, of course, all of the countries, more than 30 at this point, that have gone through this process and have allowed WHO to learn and actually be able to now make this presentation to you. There's a bunch of partners that have also accompanied countries throughout this process and accompanied WHO, so we thank them. And we also thank Dr. Daniel, the director of GMP, Noor, who's, I believe, there with you, and everybody else in GMP. So thank you very much. I'll be here connected if you have any more questions.
Thank you, Bear, for saving us a few more minutes. Can I ask Ed? Yes. And also Owusu from Ghana, please, you can come over.
Nice to see you all, and thanks for having me here to give this presentation. this will be a bit more of a general presentation about the kind of challenges we are seeing countries that we have grants with face for the upcoming grant cycle, and the range of kind of general approaches that are being used to address those. So many of the programs are already here and will be speaking over the next couple of days of their own specific challenges and approaches they're taking. So I'm not going to go into detail on the specific countries, but rather talk in the generalities of things we're seeing across the grants. So we'll talk about that, the challenges, seeing how they're being addressed, and then also seeing as there are so many program colleagues in the room, just some practical information sharing about prices and lead times, just to make sure it's front of everyone's minds. Does anyone else hear feedback? I'm having this, is that just me because I'm standing here? Is it fine? Shall I continue? It's fine, okay. Okay. So we all know this, there are many faces, many challenges facing programs at the moment, but I do think it's worth just to reflect slightly on some of the things on the right-hand side. So programs have the challenge to try and address the pyrethroid resistance on the left, but in the context of this really quite large and growing range of other programmatic financing and other external issues. So I think maybe just a couple to dive in on, the durability of the nets. So let's broaden that to say the field performance and the durability of the nets. That remains a big challenge that, you know, we've talked a little bit already today about the challenge of finding money to change between net types to move toward the better nets. Yet at the same time, there are other things that could be done with the money, such as buy more nets to deploy them more frequently, because we know the nets aren't lasting between campaigns. So there are a lot of possible approaches to using the funding available, which makes it even more challenging. And then on the lower side, there under the external issues, I think it's useful to reflect a little bit on the population growth, which is really quite phenomenal when you start looking more closely at the numbers. So since 2002, so over this period of time we've been discussing this morning, there's been a 41% increase in the population in the countries where we have financing grants. So if you reflect back on some of those financing graphs we saw in the earlier presentations, financing has grown a lot up to around 2009, and then it's stayed relatively steady. Yet the population have not stayed relatively steady. They have continued growing. So in fact, in terms of financing per person, we're almost going backwards. So the challenge to maintain coverage, expand coverage with more efficacious and expensive nets is really difficult in the context of reversals of actual cost financing per person. So how are we seeing these challenges surface in the Grant Cycle 7 grants for the Global Fund? So in different ways, really, and it's changed a little bit. The picture's changed a bit over the period of the last year. When the first programs started bringing their funding requests, countries were often front-loading funds to cover the full scope of services that they knew they needed to deploy in years 1 and 2, and leave big funding gaps, like all of case management in some cases, in year 3. Then we saw a change in that approach with a kind of acknowledgement, helped with guidance from some of the key partners, that actually case management, or at least the foundational public sector piece of case management and community case management, really needed to be funded throughout. And then looking at how far the rest of the funding could get. So since then, and during this period that we've just almost completed of grant making, that's the picture we are seeing now, with case management pretty much funded throughout, but with really quite significant gaps in vector control, seasonal malaria, chemo prevention. So on the right there, you can see if we look at the net specifically, 18 countries have around $310 million of gaps for ITN campaigns. Okay, so what's being done to try and deal with some of these challenges? First, I'm going to talk about some of the things that are happening at the secretariat level at the Global Fund with partners, and then more about what's happening at the programmatic level and what approaches some of the programs are taking in our grants. So first of all, there was efforts to try and bring down the prices of the more efficacious nets that we really hope programs will be able to deploy more. So along with the Gates Foundation, our procurement teams set up a revolving facility, which we don't need to talk about why it's called that. It's a slightly odd name for what, for all intents and purposes, is some volume commitments to suppliers, which is different than how we have approached net procurement before. So with those agreements with BASF and with Vestergaard, the two current chlorphenapine net suppliers, there was a possibility to bring pricing down, and that changed pricing has brought down the price for scaling up the chlorphenapine nets by around $62 million compared to where the pricing was before those agreements were in place. So those savings in inverted commas, I suppose, the sort of savings from where we might have been, have enabled more nets to be, more numbers of nets to be built into the grants, but also more of the more effective nets. So on the right-hand side here, these are not actual nets that have been deployed. These are projections for the types and volumes of nets that will go out during grant cycle 7, and what those projections looked like over the period of time when these discussions were happening last year. So before the new pricing, the expectation was at the bottom bar there, and where we are right now is the top bar. So there are more nets, just in terms of actual numbers of nets being afforded in the grant cycle 7 grants, and a much higher proportion of them than previously thought would be the chlorphenapine nets. So that's a very positive place to be. And then this one is, it reflects some of the data we saw earlier in the net mapping. And, oh, have I not even acknowledged it? I apologize. The bottom 4 bars are net mapping data. I should have put that on the bottom. And the top bar is, so the bottom 4 bars are actuals, and the top bar is, for the Global Fund, the proportion of nets of different types that we're expecting in grant cycle 7. So as Sid mentioned earlier, we've progressed much further than was originally expected in the CHAI short-term and long-term forecasting, as was mentioned during that presentation, because of the new pricing. So we're already, what those data, the forecast data we're projecting, we're already at 2032 in terms of the split of the different net types. And just to mention that this is based, this is thanks largely to the pricing negotiations that have been happening recently, but also to a very long period. Well, 8 years is not long in the context of what we've discussed in the last 20 years, but 8 years of catalytic support for these chlorphenapine nets. So starting back in 2018, and that was after a long period already, very long period already, of development of the Interceptor G2 product. But then there started a period of catalytic financing by the Global Fund, UNITAID, the Gates Foundation were involved, the President's Malaria Initiative were involved, focusing around trying to bring Interceptor G2, which was the product that innovated in that space originally, to the marketplace, build the data, get the prices down, get the manufacturing capacity up. And that was a long period of intervention that have brought us where we are now with the new pricing, and happily with a new product as well from Vestergaard on the market. So then on the more programmatic side, these points are really the kind of activities that programs have been looking at during grant making of the grant cycle 7 grants, to try and find efficiencies to enable them to pay for the type of nets they want to include. So programmatic modifications that can try to bring down the cost of the overall campaigns. So new and more opportunities for integration are being considered, new use of existing resources instead of new ones. So really nitty-gritty basic things, you know, working with CHWs when there's a digitalized campaign, looking at what mobile phones already exist instead of buying new ones. Looking at adaptations. So for example, we learned with COVID that door-to-door distribution can be very effective. And in some cases, door-to-door distribution will be the most efficient and actually, in some cases, cheaper way to do a deployment. And in other cases, more cases, a fixed post distribution would be the cheaper way and equally effective. So taking more nuanced decisions on what is the right approach for my setting to achieve what I want to achieve with the most efficient use of funds available. Some countries are also looking at reducing coverage in areas with the lowest transmission already in the grant development. Bayer talked about microstratification, and that's being done more and more in the urban areas. So with those kind of efficiencies that have happened during grant making, the price changes, all of the kind of looking at every single budget line to look where we can find efficiencies and make sure every dollar is spent in the most impactful way. We did make some progress, or the programs did make some progress on reducing the gaps. So we started with a gap estimated at around $475 million. And with all of that work just described, we're now at the point I had in one of the earlier slides, 310 million gap. So it's a good improvement, but I don't think anyone's going to suggest that a 310 million gap is a great position to be in. So I also wanted to mention that we talk about 18 of the countries having important net gaps, but that also doesn't really tell the full picture. The countries that don't have, in inverted commas, net gaps do have gaps for doing the most impactful, even most efficient program that could be designed. So the countries described as not having gaps is basically maintaining essential commodities, essential programming, and not looking at innovative approaches, not looking at always having the best, most effective tool, and looking at the challenges we saw on one of the earlier slides. We know we have problems with durability. We know we have problems with achieving and maintaining coverage, with use. And at the moment, given the funding constraints, we're really treading water. We're just maintaining what we have been doing, but we haven't yet, during this grant cycle, seen a great opportunity to be able to explore some of the other things that we probably know could be improving as well. So then going a bit further forward, those gaps still exist. So what are countries doing to try and address those gaps? And this is the slide where you will hear much more color over the next couple of days from you all, from national programs themselves, who will talk about some of these different approaches being taken. And these are contradictory things on this slide. These are different angles that programs have come at the issue, and they come out with often different decisions. And that is perfectly appropriate because different decisions will be right in different contexts. So some country programs are deciding to maximize the effectiveness of the tools they're deploying at the expense of coverage. So by that, I just mean buying more better nets instead of, buying fewer better nets instead of buying more less good nets. And looking at, in the red here, I talk about the different modeling support that's being done, looking at nationally specific models to suggest that that might be the better way to avert most cases, but of course brings a very big political equality, all sorts of other issues around the idea of limiting coverage and providing a better tool to certain families and leaving other families uncovered. So the second point is about basically the complete opposite decision that some other countries are taking and saying, okay, it's absolutely vital that I cover, that I give nets to as many families as I possibly can at malaria risk areas. And so I'll upgrade, in inverted commas, the best number of nets that I can, but not at the expense of leaving people uncovered. Then there are other programs that can't even achieve coverage of the whole population with the cheapest net available. So there are even more dire financial situations in some few countries. And then, of course, it's not just decision within nets. It's not a fixed net budget, often at the start of the discussions. So some country programs are saying, well, I need to make sure that I have either PBO or clofenapir nets in all my risk areas because of my pyrethroid resistant situation. So I will have to take that funding from the SMC pot or from a different area of the grant. Other countries are not doing that. They are just saying, this is my net budget. Let's see how far I can stretch it. So just in the bottom, I wanted to talk a little bit about how important we are seeing the modeling support being this grant cycle to help provide some information to guide some of those discussions that have to happen at country level. So obviously, it's not that the modeling results should be the decision. They should be a set of information to guide the national decision about how best to take an approach that works for all the things we have mentioned, the politics, the equality, all of those things that are important alongside effectiveness. But I think we're going to see that being, I can't actually read the red over there. I think we're going to see that being more and more important. And I mean, we are seeing some of the models show that the first choice, taking the more impactful tool and leaving areas uncovered. We are seeing that in many settings as being the way that's modeled, at least, to show most cases averted. But these models really do need to be country specific. So I think that's probably the next AMP meeting is going to be still about modeling. And this is really just to show how far we came given all of that in terms of a shift of net types. So I'm really regretting this color choice now. I'm going to have to go and look over here. So this is trying to show how far countries have got in terms of moving towards a better type of net. So dark green is basically you're in a good situation. So it actually also encompasses countries that don't have documented pyrethroid resistance, because even if they have pyrethroid only nets, because we could say, have the right tool for their setting, at least for the short term. But for most cases, the green is countries with pyrethroid resistance who have managed to budget in Grant Cycle 7 for a complete a total net set of volumes, which is either PBO or clofenapir nets, no pyrethroid only nets. And then the blue ones, there's a mixture, I think. Yes. So some of those countries, so the countries in blue have pyrethroid resistance, but still have some proportion of pyrethroid only nets within their campaigns planned, purely because of budget constraints. Okay, and then this is just 2 slides just to share some practical information that you're probably all very well aware of, but just to make sure it's in the front of everyone's minds because it's quite critical at the moment. So the lead times for ordering of nets. This link here is where to get the most up-to-date information, but I just wanted to flag about the clofenapir nets. So the new negotiations with BASF and Vestergaard have meant that the lead time for these nets has come down to be in line with the other net types and is around 6 months, which is very positive. However, because of what we saw on some of those earlier bars, the massive shift towards clofenapir nets, there is high demand, and we need to be really careful in terms of planning our procurements, PMI procurements, AMF procurements, against the supply available from the 2 suppliers. So there's a lot of careful work being done, similar to how we do with SMC commodities, to make sure that it's very carefully mapped out so that those national programs who would like to access clofenapir nets are able to do so. So this is the request I am passing on from my procurement colleagues, which is information that's been shared already with your country teams and with the PRs about the ordering dates for clofenapir nets. So the request is at the moment, to spell it out in red, but by the end of February, it's requested that programs who are planning to order within their Global Fund grants clofenapir nets for deployment in country by mid-2025. So those orders should be in by 29th of February. There is, of course, opportunity for countries who later want to increase the volumes they're asking for or request additional volumes if they haven't even requested clopidogrel volumes, and those can be discussed perfectly freely. But to have a really good picture and make sure that supply and demand are being carefully mapped out, that is the request. And then just a reminder that this is the link where you can get the pricing information. So it's set out differently than it used to be. The first landing page will take you to this table, which you can barely see, but there's the link, which shows you the pricing for the three different types of nets for the four most commonly procured colors and color and size combinations. And then if you click the link halfway down the page that little arrow is pointing at, that takes you to the bigger table, which shows you the pricing across the whole range of sizes. And the prices are very different. For the clofenapir nets, the prices are very different for the wider set of sizes than for these four most commonly procured sizes and colors. That's why the focus for the Global Fund grants is on these ones, to ensure that we can buy the most nets possible, really, and that the programs are able to deploy as most nets as they can to families. Okay, I think I will end there. Thank you.
Thank you very much, Kate. At this point, can I take 3 questions to Kate and to Beatrice? Okay, we start here. Could you kindly use your mic and just ask your question?
Hi, good morning. Sorry, let me just try and stand up. Patrick Sees, Head of Global Growth at Vestergaard. Thank you, Kate. That was absolutely fantastic. I had a question. You initially indicated resistance to pyrethroid is entrenched and widespread, which is now well documented. And yet I was wondering about the proportion of pyrethroid-only LLINs that still exist. Perhaps you could speak a little bit to that. I know you alluded a little bit to it, but if there's any chance you could expand on that. Thank you.
Thank you. I'm Joseph from South Sudan, National Malaria Control Program Director. I have 2 questions to the last presentation. As mentioned, any order for 2025 should be made before the end of 29 of February this month. And we had an evaluation recently in our country about the distribution of nets that always fall on the last year of the grant. It always causes a lot of inconvenience. So we thought of even having it on the second year of the grant. But my question is, when we have seen the manufacturers' distribution across the globe, they are mostly overseas. Can we make an effort of having in-region production of the nets so that the requests and supplies time can be shortened? That is 1. 2, okay, thank you because of time.
Thank you very much, and thank you for that excellent presentation. Mine is just a comment regarding campaign designs to improve efficiencies. And my name is Teshoma Gaure. I'm coming from the Task Force for Global Health. And the task force, we have now a new program called Health Campaign Effectiveness. And this health campaign effectiveness is now trying to deal with health campaigns that are involved in mass campaigns, especially for malaria in the case of ITNs, and combining them with some existing other interventions like immunization or like master drug administration for NTDs and so on. So I'm just trying to now simply provide information that this health campaign effectiveness is now being piloted in Ethiopia and Nigeria as of this year. And we had a planning meeting just last month. So perhaps this could be an information, and perhaps later on, we want, based on the experience in these two countries, we want to replicate the experience to the rest of the African countries. So that might be one good news for this group here now, which is struggling to improve efficiencies in IT and distribution. The second one is just a question, a quick question. With IT and challenge, the programmatic challenge, we have a number of them, but one is use of proper use of bed nets. So I'm wondering if we have really made any progress in coming up with increasing or making effective use of nets by households, especially in the rural areas. In my country, Ethiopia, we have seen, abuse of misuse of nets very widely in the villages. In 2007-8, we had the largest, universal bed net coverage, distributing something like 20 million nets. And in fact, that had a significant impact in reducing the malaria prevalence in that country. But at the same time, we were so, disappointed when we see in some villages that people were using the bed nets for some other purposes. So any new, since I'm coming back to the malaria program after so long, I'm just wondering if there have been any innovative approaches to really increase the effective use of bed nets. Thank you.
Okay, can we respond? I think you do the response, then we do one more round. Thank you.
Thanks for all those questions. Okay, so on the pyrethroid-only nets, there are still a number of pyrethroid-only nets going out to countries with pyrethroid-susceptible vectors. So those figures shown were for all the nets supported. For the Global Fund figures, it was for Global Fund nets supported globally, which does include quite a few nets going outside of Sub-Saharan Africa. Obviously, there's pyrethroid resistance outside of Sub-Saharan Africa as well, but some of those are going to countries with pyrethroid susceptibility, and the rest of them are going to countries who decide that coverage is so important that they will deliver some pyrethroid-only nets in areas of pyrethroid resistance as a tool that is still recommended by WHO, not as strongly recommended for sure, and not as efficacious for sure, but for national programs who take that decision that coverage of families with a tool is better than leaving some families uncovered. So it's probably about half and half of those pyrethroid-only net numbers going to areas where it's really a sound, efficacious decision, and then half being areas where we would really rather see something else going out, but it's a very challenging financial situation to be in. And for the question from the South Sudan colleague on local production, yes, there is a lot of conversation around opportunities to move to regional production closer to where the nets are needed. I will just put in a plug for my colleague Sid, who will be talking later on the agenda with Lilia from PMI, and they will mention some of the issues around that, I think. And if they don't, he's the right person to ask that question to, so I'll hand on to him. We also obviously have some suppliers, manufacturers in the room who may be able to give you updates on the discussions that are happening in that space, but it is certainly a really key issue at the moment. Thank you for the reminder about the Health Campaign Effectiveness Coalition. Global Fund's quite involved with that as well, and I think my colleague Patrick was just with you in Ethiopia. So we're really interested to see how that goes and how that builds on all the other work that's happening with partners such as AMP on campaign efficiencies and opportunities for integration. I think the key there will be making sure that all the experience that's been built already and all the partners that are already working in that space can all come around the table and make sure that we can move to a space where campaigns are more effective, and that the process to get there is also effective with all the partners being involved. And then use of nets. Yes. So this is something that I think it's some of the things you just talked about a large number of nets having been deployed. And yes, we have seen impact from those nets, but there is also misuse in some cases of those nets. That is a sentence that is repeated over and over again by different, often ministers of health. And I think it's really important that we talk about that. And I don't think it's a big focus of the agenda this week, but I think it's not so much, not the elephant in the room, but I think it's a really big concern, this chipping away at the confidence of nets as a tool for malaria control, with people pointing at durability, yes, but also use. And I think the concerns around net use are completely intertwined with the problems of net durability. Because when, as we all know, when we look at the data, in general, if people have a net, they are using a net. And certainly when there are not enough nets, the most vulnerable people are absolutely being prioritized to use those nets. So the biggest win, the quick, to make it sound easy, but the quickest way to increase use of nets is to get more nets to the families who need them. And that's, that is a really important message that we should all keep saying, because just because net use on average in sub-Saharan Africa is at 56% or whatever it is, that's not because 44% of the nets are not being used. It's because there aren't nets. That's why net use is looking so depressingly low. We need to have more nets, and we need to have financing so that programs can deliver the nets that they need to deliver. But that perhaps is too simplistic a way that we have been looking at it. And I do really agree that maybe now's the time to get more nuanced on looking more closely into those data. So whilst we absolutely, and I will repeat it, whilst we absolutely can say most people who have a net do use it, there are differences, there are subnational differences in use rates, and that's what we should be looking at. That's the kind of subnational tailoring that would be helpful as well, to look at where should we subnationally tailor our SBCC interventions. And I'm sure you all know the Breakthrough Action website, but that's an absolutely fantastic source of information on subnational variations in net use given access, linking directly to recommendations as to the types of approaches that could be taken to try and intervene, to try and improve net use. I think that's PMI supported, better say that.
So we have 5 more minutes for one really burning question. Yes.
Thank you, Alexis from Cameroon. My question has to do with the coordination amongst donors in general, Global Fund in particular, and WHO. I'm talking about the high burden, high impact approach, because I do not have the impression, the perception that these countries, high burden, high impact, are treated differently. So my question is, how do Global Fund prioritize these countries, given the level of gaps that we are observing in some of these countries? Thank you.
So one of the, well, I guess the biggest thing I will point to is that the allocations that the Global Fund supports national programs with are very closely linked to the burden, historical burden of malaria. So the countries with the highest historical burden of malaria are the ones who get the largest allocations of funding. But yes, it is more complicated than that. And there are some high burden, high impact countries who have had reductions in funding because of the massive need across the continent. So, I mean, perhaps Bayer also could speak to the HBHI approach if she's still online answering questions. But certainly within the Global Fund, part of it is about division of resources, and part of it then is about linking the country teams within our secretariat and the national programs to that partnership approach, and ensuring that the subnational tailoring support is happening. And we rely very much on that subnational tailoring modeling when evaluating the grants and looking at grant making processes to make sure the most impactful interventions are put together to make sure those grants have the biggest impact they can. But I really do agree that it's challenging to see how we move from where we are now, because there is such widespread need in countries with moderate burden in sub-Saharan Africa is still massive burden of malaria. So it is very challenging to work out how best to prioritize resources across those countries, for sure.
I don't know whether my colleague is still online to make a comment on prioritization in HPHI countries. Do we know if Bea is still online?
Hi, I'm still online.
Okay.
Just a very brief comment that HBHI countries have been the countries that have received the S&T support for the longest time, as well as other types of support. So that's the extent to which we have made sure that their evidence is used for the most appropriate and impactful decision making.
Okay, thank you very much. We'll end there, and now let's listen to results of stratification in Ghana from Dr. Owusu. I think this is one of the country case studies. Very interesting.
Hi, everyone. Hi, everyone. Can I be heard? Okay, great. Great. So I'm going to bring into the Ghanaian context the presentations of Beatrice and Kate. Okay, so I'm going to speak on these. For malaria burden worldwide, as at 2022, we've recorded some 249 million cases worldwide. The African region, unfortunately, holds a very high proportion of those cases, 94% for the cases and 95% for deaths. Again, unfortunately, children under 5 within the region also holds 76% of the malaria deaths, which is also quite high. I think this needs more energy than I currently have. Okay, so in Ghana, the burden is also quite high, as we see that Ghana is one of the high burden, high impact countries. And so over 30 million people in the country are at risk of getting the disease all year round. And the 5 mortality rates sit at 52 per 1,000 live births. We have parasite prevalence of 8.6 across the country, and we record some 0.5% of deaths that are due to malaria across the health facilities. So Ghana can be seen to have 3 ecological zones, and malaria transmission is varied across these zones and also varied across the 16 regions that we have. Malaria is one of the highest disease expenditure for the national health insurance schemes we have, and also a GDP reduction by 0.5 to 6%. Majority of the vectors we see in Ghana are Gambi, Phenestus, Arabiensis, and quite recently we've seen Stephensi in selected areas as well. Plasmodium cases have falciparum being the highest. We see a bit of malaria and ovale as well. We are yet to record any cases of vivax in the country. So this is how our prevalence stands. We have come from having very high prevalence of about 27.5 to currently 8.6. And this has been largely due to interventions like nets, case management, indoor residual spraying, etc. So we're going to focus on the vector control interventions we have in place as a country. That's distribution of ITNs, endoresidual spraying, targeted larval source management, and entomological surveillance. I must say that within our new guidelines, vector control guidelines, we have made room for new tools like ATSB repellents and the like, but these are all subject to country evidence of efficiencies or efficacies within the country. So zooming in on ITN distributions, we have two main channels, mass campaigns and continuous distribution. So for mass campaigns, it's done every 3 years, and it's focused on getting nets to every 2 people in a household being entitled to 1 net. Over the years, we've come to a point where this is also not a one-size-fits-all across the regions or across the various urban and rural divides. So for the current mass campaign we have started this year, we are looking at between 40 and 90% of coverages, which cuts across the urban-rural divide. For continuous distribution, we have health facility, child welfare clinics, antenatal clinics, and also school-based distributions. These are done in years where we do not have mass campaigns, but health facility distributions are all year round. And most recently, new babies, that is nets to HIV and TB clinics. We are still trying to get this to be as efficient as the other channels. It's a work in progress. So zooming in on stratification, strategic information is taken for Ghana based on the evidence that is available. And this would go into the kind of tool that is put in any place at any particular time. So we look at appropriate entomological context-specific interventions that would maximize impact. So in line with the interventions that are available against those that we can actually get because of cost and other implications. And so in doing this, we put into focus getting systems in place that will give us the requisite data when it comes to taking those decisions. So we have the stratification exercise in itself. I would mention that again in the next slide. And we have epidemiology data that comes from the routine systems, that is the DIMS, and also from our and the sites that we have, the Sentinel sites across the country, which in recent years, we have made sure those sites that pick epidemiology data are the same sites that pick entomology data as well, so that we can juxtapose these two. So in addition, we have insecticide resistance data coming from 30 sites across the country, which also inform the decisions that we make. The other thing we take into consideration is looking at the intensity of the disease and the impacts we want to make. Where do we put which tool? We also bear in mind as a country that because we have funding gaps, we do not put 2 major vector control interventions in one place. So we don't have places that do indoor residual spraying, doing mass campaigns, for example. And we'll see that in the next few slides. So in our stratification exercise, we first considered prevalence, and we looked at the burden of the disease in this context. We generated the first map you see on the left, where we were able to segregate the various districts and regions into high, low, medium burdens. Then we looked at under 5 mortalities across these same areas. We were able to also put the country into these contexts. But then juxtaposing the prevalence data with incidence data and also under 5 mortalities, we came up with the map on my extreme right, which gives us a better idea of which areas in the country, districts, would most likely benefit from what intervention because they have the highest burden of disease or medium or low or very low. So in doing this, this is the map we were able to generate. And this clearly states in each district the kind of interventions that would apply. So I can't see too well from there. So for example, for the ones with, let's take the very, glaring color. For the red areas, for example, we are talking about a combination of case management, IPTP, post-malaria discharge, early lines, SMC, and the malaria vaccine. So all of these areas have specific interventions that we are going to put in those areas. So this cuts across all the interventions, not just vector control. Zooming in again on vector control and ITNs, we looked at the various information that was available. So in our prevalence data, we got information mainly from surveys and previous stratification exercises. And we also considered the change in burden of the current or the most recent stratification exercise compared to the last one. And we come up with a difference. So we have areas where we've seen increases, reduction, some were also the same. And we also considered the rural-urban divide, because in Ghana, most of the urban areas would prefer not to use a net. And so we waste a lot of time and money when we focus on them. So that was also taken into consideration. We also looked at the type of nets that particular area got in the previous campaign vis-a-vis the increase or decrease or maintenance of the prevalence levels there. And the seemingly last but very important consideration is on the quantities that we have available as per the costs and what we have allocated per our strategic plan, per the monies available, in context with what Kate was mentioning. And so in doing this, our only choices, which is good because in previous years we had only pyrethroid nets, in spite of the fact that we have recorded high levels of pyrethroid resistance. So this is a blessing that we're able to choose between standard pyrethroid nets, pyrethroid PBO nets, and the new nets. And in Ghana, we chose IG2 because of the texture of the other new nets. So in saying this, these are the various scenarios that played out. Again, let me switch to this. So looking at scenario 1, the question is, what is the current bedding? Has it improved? Has it worsened since the last stratification? So let's say, for example, in the districts we are considering, it improved. So the next question is, which net was given the last time that we did the mass campaign? So we have an area which has improved in bedding, and we gave them standard nets. Is the area rural or urban? We say that it is urban. If it is urban, knowing what we know about urban nets, and in spite of the fact that that area would have insecticide resistance or not, we still maintain standard nets. Because I told you we don't want to put too much effort into the urban areas lately. So let's take the second scenario also. The question is, what's the current bedding? Has it improved or worsened from previous stratification exercises? In this case, it's worsened. The kind of net that was given the last time was a standard net. Is it an urban area or is it a rural area? It's a rural area, so we need to pay attention. So then we move into giving that place, that should be PBO, sorry, a PBO or a new net, because we know that the situation has worsened and it's a rural area, they are most likely going to use the net. So we give them a PBO or new net. Then the question again is, has that area received new nets previously? If the answer is yes, we maintain new nets in that area. And we also need to ask ourselves, can the quantities hold? The number of nets that we know is the bigger pots that we are picking new nets from. If we add this district's quantification to it, Will the quantities be able to suffice for these areas? If it is yes, we go ahead and give new nets. If it is no, we revert to giving a PBO net instead of a new net. Okay. Now, the third scenario, question again, what's the current bedding? Has it improved or has it worsened over the previous years? We are saying that it's reduced, so it's improved. And which net was given the last time? This area was given a standard net. Is it a rural or an urban area? It's an urban area. So we give a standard net. I've explained this already. However, we again, at this point, look at the insecticide resistance in that place. If we realize that it's one of the areas where we record one of the worst intensities for insecticide resistance, then we give that place a PBO. Again, the question will come, can the quantities hold? So if we can't give a PBO because the quantities cannot hold, we give a normal pyrethroid net. So the last scenario we'll look at, same question. The bedding is maintained, or there's been a very little increase in the bedding. So the net that was given the last time is a standard net, and it is a rural area. So we maintain the standard net. However, because the bedding has been maintained, or we don't see too much of a difference, we can go ahead and give a standard net. But again, we look at our insecticide resistance data. If that area records one of the worst, like a typical area in Ada, which we realize there are other activities going on there, so insecticide resistance there is high, then we go ahead, intensity of resistance is high, we go ahead and give PBO nets. The last question also holds. Can the quantities hold? Because of the pots we have and the number of nets we can give in all. What just happened? Okay, so in doing this for 2021, there's a kind of stratification that we got for the types of nets to the various areas. So the plain areas are places where they have they have indoor residual spraying, and so we don't give nets in those areas. The places in orange are places where we give standard nets because of all the considerations we've earlier made. Those in light blue have PBO, and those in green have the new nets, in this case, only IG2s. So the good thing about the 2021 versus the 2024 campaign is that in 2021, we were only able to give new nets to just the two regions. Those are the Western regions, Western and Western North, because the question of can the quantities hold? We had very few new nets by then, so we put them there. So in 2024, that's the current campaign we are running. We can see that a similar thing applies. However, we have a lot more new nets now compared to the others. So in 2024, we have PBOs being the highest, followed by standard and then new nets. So the deep blue are the new nets, that's the dual AIs, and the light blues are the PBOs. The rest are the standard nets. So you can see that the standard nets, which is the light green, is very few this year compared to the previous year. And for us, this is really good news because it means that as a country, we are actively doing something about our insecticide resistance issues and not just sitting down with our arms folded. So this is what we saw after the 2021 campaign, when the survey was done in 2022, that prevalence levels had really decreased remember these two green areas, the Western and the Western North regions. Look at it in the map on the right. You can see that prevalence is now between 4.4 and 9.7. We used to record prevalence there of 27%. So it means that the new nets, again, the only new thing we did in that area. So this is not to say we didn't have case management or all the other interventions going. The only new thing or the only addition were new nets, and we saw this change. So I would leave that with you for you to chew on that for a bit. Point is that when countries actively do this stratification, it's not just a one size fits all for everyone. And I feel very fulfilled because we are proactively doing something about an age-old problem of insecticide resistance. And for us, this is great. This is a big move from what we used to do in previous years. We are saying that to do this, it's a logistics nightmare because in any particular region, you could have that region receiving all the different types. And to be able to get your supply and logistics people, for them, they really don't care about whether it's PB or net. You've asked them to move 500 nets to an area, so they are moving it. But for us, to get them to move the correct kind of net to that particular area because of this sub-national tailoring we've done, it's very important. It's not easy, but it's something that we've been able to do well because we tend to plan early and we have a lot of committed people who are willing to make this happen. So in conclusion, the country looks forward to more achievements in this regard. That is, being able to actively decide on the type of net material that is procured in order to also not just affect coverages or prevalence, but to increase the reduction in prevalence by also affecting usage. We know for a fact that in Ghana, most people prefer the polyester nets because the polyethylene nets, we see them using for other purposes, because according to them, it is harder, for lack of a better word, a more durable fishing net or a more durable garden net than using it for a bed net. So we look forward to, as a country, being able to also take the decision on the type of net material, and we know that this will positively increase usage coverages across the country. Eventually, we know that resistance issues are over years, but we know that being also proactive about this will ensure that after some years, we would see some changes in our resistance profiles across the country. We really look forward to this. Thank you very much.
Well, it's very interesting to see the examples of Ghana and how districts have moved from one prevalence to the next. So questions, I know the energy in the room. Let's start with you.
Thank you so much. It was really nice presentation. Is it fine? Is it better now? Thank you so much. It was very nice presentation. I have just a question regarding the stratifications you did. You suggested that there was 2 scenario improved and the worst. And so what are the factors? Did you saw the utilization? Survey has been done in both areas, is the same things. And the second thing
I'm
is.
sorry, I can't follow. Please speak slowly.
Oh, sorry, I thought it's. Can you hear me? Okay, sorry. Thank you so much for your nice presentation. I just wanted to understand about the stratifications in which you placed 2 scenarios. One is worsen and the other one is improved. So there was a utilization survey as was done also. And secondly, regarding the population. So you did the population because there are some areas, maybe migrants are from the other borders, populations are coming. So the population is the same and the utilization was the same in both areas? Over.
Merci. Permettez-moi de casser un peu l'ambiance. Je vais poser ma question en français. Dans la carte composite que vous avez présentée de stratification qui prend en compte l'incidence, la prévalence et la mortalité chez les enfants de moins de 5 ans, c'est bon? OK. OK, je me répète. Donc, la carte que vous avez présentée, la carte composite sur la stratification du risque qui prend en compte l'incidence, la prévalence et également la mortalité chez les enfants de moins de 5 ans. Je voudrais savoir, dans le cadre donc, du SNT que vous avez fait au Ghana, quel est le niveau d'ajustement de l'incidence que vous avez utilisé? Donc, est-ce que vous avez fait le niveau 1 ou le niveau 2 ou le niveau 3 qui prend en compte donc, la recherche de soins en population? Donc, ces indicateurs estimés à partir des enquêtes de prévalence du paludisme, donc qui sont des données à l'échelle macro, souvent régionale, qui ne sont pas disponibles pour le niveau district. Donc, quel est le niveau d'ajustement de l'incidence que vous avez utilisé? Merci.
Merci. Elle a dit au cours de sa présentation qu'il y a 30 sites d'études entomologiques et qu'il y a eu aussi l'apparition de Anopheles stephensi. À quel niveau se situe la découverte relativement à ces 30 sites-là? C'est dans combien de sites vous avez pu découvrir? Merci.
Hi, excuse me. Otibia, that was a great presentation. Thank you very much. I'm over here. Hi. I have two quick questions for you. One is I found it interesting that for the HIV and TB clinics, you've got them within your pool of targets. But I'm curious if that funding is coming from malaria specifically, or if that's also coming from HIV and TB. So sharing that kind of funding stream. And then there was another question around channels. Are you aligning the type by channel or by region or other criteria? Campaign versus CD.
Can I just encourage us to introduce ourselves when you're asking you?
Right, thank you. My name is Zainab Ali. I'm from Nigeria. Thanks for the great presentation. So my question is on the part of it has been asked by Jessica on the funding from the special groups, HIV and TB. Then looking at those groups, how do you manage the distribution within those groups? Because from experience, they can go to other facilities to access care. So if they move between facilities when accessing care, how do you manage so that you don't keep giving them nets as they go around facilities? Then how did you quantify for those groups? Looking at there within the general population and with the scarce commodity resources, how are you managing so that you don't over quantify the ITNs you are procuring for the country? Thank you.
Okay, we'll let her answer, then we'll come. If we have more time, we'll do another round.
Okay, thank you all for your questions. So the first one was use of, I'm sorry, I missed that again. Okay, let me pick the others. I'll come back to it. The other was on the incidence levels. So I was trying to recall as I sat here, but I didn't. So I'll quickly check for you during the break, and then we can discuss that one-on-one. Okay, thank you. And the level of discovery of Stephensi. So we have 30 sites in the country, and within that we have 20 other sites, that 30 for insecticide resistance and 20 for entomological data itself. But the places we discovered Stephensi are not in any of those areas. However, we have a flag on all the samples that we collect from these areas to look out for Stephensi since we discovered it last year, March. But so far, we haven't had any additions coming from those sites. So it is just in selected areas in the Greater Accra region of Ghana. I hope that answers that. And the other is HIV, malaria. So this is within the malaria grant. And we get data from the HIV, TB colleagues. We sit around the table. They give us information on the numbers they saw the previous year. We look at a number of years, and then we average it off. But we have functional TB and HIV clinics scattered across the country where every patient that is positive for any of these goes to those specific clinics. And so what we do is that when we are sending nets for child welfare clinics and antenatal clinics, we add those nets to it. So it's the same pot that goes with clearly outlined this quantity for this, that quantity for the other. And we have TB, HIV coordinators in the various clinics that liaise with the malaria focal persons to get those quantities that are allocated to them within their districts. And we also make sure that, for example, in Western North, that year we did mass. After that year and after, all the nets that go there are new nets. So we try to align it such that if you get standard for mass, you will get standard for continuous distribution as well, and also to a large extent schools. So that is it. Yes, I think I answered every question but yours.
Yeah, I think what she asked was whether you collected any data on use and also whether you counted on population movement.
Okay, great. So the use data, unfortunately, is not routine. We don't get that routine. It's on surveys. Again, unfortunately, we don't also get it per districts as we would like it to. It is always per region. So we were not able to juxtapose the parasitemia levels we are seeing in those areas with the usage when it comes to districts. We didn't do that. We have end user surveys at the end of mass campaigns that also look at usage in addition to the survey data, which we really didn't consider in this the stratification exercise. So levels of use when it comes to ITNs, from where I sit, is very low. And it's something that we want to change. And so we don't use that data, even as small as it is, or at which level as it is, to make decisions like this. We haven't done that yet. Thank you.
Okay, one more question, one final one at the back.
My name is Duncan from Kenya. Let me start by saying congratulations to Otobi and the team, because it's really remarkable to see all the benefits you're getting in terms of a reduction in parasite prevalence. My question goes to asking about the full change all the way from 2016 to 2022. If the team is actually analyzing the full scope of all the aspects that were put in place and all the things that were done right to make sure there is such a reduction, because it could be a learning for many countries. Particularly, you mentioned aspects that are not necessarily always measured, such as the type of material on the netting. And maybe a retrogressive analysis could probably inform for other countries to benefit as much as you have.
Duncan, if you can repeat your question again. I only heard the last bit on the type, but not the...
So my question is, are you going to do some form of analysis and trend outlook to, as a useful tool so that other countries can learn from what you've done? Particularly, you mentioned an aspect of the type of material on the net. Maybe this could be influencing net use, and maybe some analysis on that could help accelerate it.
Okay, so we have scattered data on... Okay, let me start from here. We know as a country the preference of the type of material, and we have data which is not a country data, but data on areas on the use as per the preference. So it is one thing that we are discussing and talking about most recently, because usually the type of material we want is not what we get due to some procurement, what's the word? Procurement phrases, let me put it that way. And so what we want to do, or what we are doing this time round, I was having a discussion earlier on that, is that in addition to the questions we ask during mass campaigns, we are also including a bit that would capture refusals because we realize that that is a gap. We have people who you go to register for NETS, they are not interested, but there's nowhere to capture that data. And also you would have some of them register and get to the distribution points and realize that, oh, you are giving them polyethylene instead of a polyester. So though you have them registered and you have the nets ready for them, they don't want to take it. So we are picking data on that as well. Hopefully we can share in subsequent meetings how that went. We actually really looking forward to how that will turn out as a country, because we need a data like yesterday on this to help with all the procurement issues. Thank you.
Okay, thank you very much for a very interesting session. So we'll continue with this theme in the afternoon. And for now, because of the energy levels, I'll ask you to keep the questions because the theme is continuing in the afternoon. So we can borrow from that session and ask more questions. So we break up for lunch and we come back at just 5 minutes past 1. I think lunch is just outside. Yeah. Lunch is downstairs at the pool, but no swimming.
La morbidité de l'incidence en RDC et que actuellement l'incidence, nous sommes à peu près 27 millions, 28 millions de cas déclarés dans notre système de santé, rapportés dans le système de santé chaque année. Les décès en bas, vous voyez que les décès, nous nous sommes très bien comportés. Les décès en partant de 2015-2016, nous avions à peu près 40 000 décès. Nous avons réussi jusqu'en 2020, à diminuer drastiquement le nombre de décès jusqu'à 13 000. Mais malheureusement, lors de la COVID, jusqu'à aujourd'hui, on a vu que les décès aussi commencent à augmenter. Nous avons fini l'année passée avec 24 000 décès. Et cette tendance se conforte encore cette année. Nous avons à peu près aussi 24 000 décès pour 2023. Cette slide, je voudrais partager avec vous l'évolution du financement de la lutte contre le paludisme par les partenaires Fonds mondial depuis NMF 1 jusqu'à GC7. Vous appréciez avec moi que nous sommes partis de 100 millions. Nous sommes partis par rapport à la population. Actuellement, nous avons près de 130 millions d'habitants dans le pays. Nous allons finir les grands avec 130 millions d'habitants et qu'au tout début, c'était 100 millions d'habitants il y a 12 ans et nous avons 130 millions d'habitants. Par rapport au financement, vous appréciez avec moi que nous sommes partis de 304 millions globalement à 377,77 millions à GC7. Donc, l'évolution, nous sommes partis de 3,03 $ par habitant à 2,89 $ par habitant. Et vous le savez, la logistique mondiale a augmenté le prix, même si la moustiquaire, nous disons merci à MP, RBM et autres pour les plaidoyer pour que les prix des prix bio, moustiquaires prix bio qui étaient au tout début, il y a 6 ans, à peu près 7 $, et cette moustiquaire se vend à moins de 3 $ actuellement. Et même la moustiquaire Agitou, les plaidoyers mondiaux a porté ses fruits, mais malheureusement, la logistique internationale a son prix et il y a eu une flambée de la population de 100 millions à 130 millions d'habitants de NMF1 à GC7. Cette tendance aussi s'observe par l'autre partenaire qui s'appelle PMI. PMI, le financement était presque stable. C'était à peu près 45 millions à 50 millions depuis 10 ans. Et ce financement est toujours le même. L'enveloppe n'a pas évolué. Et donc, actuellement, PMI, même s'il nous a accompagnés pendant quelques années, mais PMI, actuellement, n'est resté qu'avec une province sur 26 Les gaps demeurent, comme vous allez le voir avec moi. Nous apprécions aussi le fait que les fonds mondiaux, les AMF, est venu à la rescousse des deux bailleurs principaux qui sont PMI et Global Fund. AMF, depuis 6 ans, nous travaillons avec AMF qui nous apporte un soutien de taille, mais malheureusement, ça ne peut pas suffire parce que, vous allez voir avec moi, nous avons été amenés, vu cette enveloppe qui ne fait que diminuer, la population augmente, nous avons été amenés à jouer ces jeux de priorisation pour que nous puissions voir avec l'enveloppe qui est disponible, qu'est-ce que nous pouvons faire? Qu'est-ce que nous pouvons faire comme stratégie? Quelle stratégie pour l'enveloppe qui a diminué? Et donc, l'unité l'unité avec laquelle nous allons travailler, nous avons travaillé, c'est des priorisations, c'était la zone de santé ou du site sanitaire. Donc, l'objectif, c'était de redéfinir les zones prioritaires qui organiseront les campagnes de distribution de masse des MILD en raison de la réduction du financement disponible auprès des bailleurs. Donc, nous sommes lancés dans cet exercice avec les partenaires techniques comme CHAI, comme l'OMS et PAT. L'OMS, on était avec Galatas, qui nous a exposé ce matin, était avec nous dans cet exercice. Please. Please. OK, ça va. Alors, nous avons travaillé la priorisation. Cette slide, vous l'avez vu quand Galatas a présenté cela qui était très attentif. On a vu cette slide. Donc, pour prioriser, nous avons travaillé avec les 8 critères, variables que vous voyez là-bas. Il y avait la transmission, les zones de transmission plus élevées jusqu'à basse. Nous avons travaillé aussi avec la réceptivité ou bien ça peut aussi s'appeler la parastémie asymptomatique. Nous avons travaillé comme variable des campagnes qui ont été organisées en simulant le fait que si on réduit, donc on retire l'organisation des campagnes, qu'est-ce qu'on peut avoir comme effet? Nous avons travaillé aussi avec la variable urbanisation, urbain ou bien rural, et l'accès aux soins. Nous avons capté cette variable. La résistance aux ACT, cette variable aussi était captée. Et enfin, la résistance aux pyrétronéides, nous avons capté cette variable et l'accès aux moustiquaires et leur utilisation, on a capté aussi comme dernière variable. Nous sommes en train de travailler avec, toujours avec Galatas pour essayer de capter dans les modèles les MBS, Malaria Bièvre-Savée, que nous avons réalisé au pays il y a 2 ans. Mais malheureusement, cette variable, on l'avait captée uniquement avec des données agrégées. Pour désagréger, ça va être difficile parce que le pays avait été divisé en 4. Je vous ai dit d'entrée que nous avons travaillé avec comme unité des districts sanitaires. Donc, on ne peut pas avoir ces données par district sanitaire, mais on peut avoir par bloc. Alors, on utilisera cette variable comme proxy par rapport au pays. Et donc, parlant de l'incidence que nous avons utilisée, nous avons utilisé une incidence médiane. Il y a une question ce matin. Cette incidence avait été ajustée par rapport au taux de positivité et au rapportage pour capter. Donc, c'est de 2020 à 2022. L'incidence a été utilisée. Nous avons aussi utilisé la prévalence, mais la prévalence, nous l'avons utilisée par rapport à… Donc, nous avons capté la prévalence de MAP. Nous n'avons pas capté la prévalence de mix. Une fois de plus, mix, c'était des données agrégées. Notre unité, c'est district sanitaire. On ne peut pas ramener district sanitaire à agrégé. Ça signifie que nous avons laissé tomber les données par l'enquête mixte. Nous l'avons déconsidéré pour réaliser notre modélisation avec des données de MAP. La mortalité hospitalière aussi a été utilisée dans les poules que nous avons fait. Donc, la mortalité hospitalière due au paludisme a été utilisée, a été captée dans la priorisation, comme vous savez. Ainsi, nous avons fait des risques composites. Le premier risque de composite a pris en compte l'incidence, la prévalence et la mortalité. Et vous voyez la carte, comment est-ce qu'elle devient en partant d'ici. D'abord ici, prévalence, incidence, prévalence, mortalité, et puis nous mettons les trois ensemble. Vous voyez la carte, comment est-ce qu'elle devient. Et la réceptivité de base, nous l'avons aussi utilisée. Nous avons considéré la prévalence falciparum de 2000 que nous avons réalisé, c'est ancien, vous allez me dire, inférieur à 60% et supérieur ou égal à 60%. Supérieur ou égal à 60%, c'est ça que nous avons capté, considéré comme une réceptivité élevée. L'accès aux soins, nous avons utilisé, il y a une question qu'on a posée à mes prédécesseurs du Ghana, comment est-ce qu'ils ont capté? C'est une donnée que nous captons en RDC en routine. Chaque district sanitaire capte cette donnée. On connaît les zones, les villages qui ont accès difficile à plus de 5 km. C'est capté en routine, donc c'était difficile. On n'a pas forcément besoin de faire de la géoréférence pour capter ces données, quand bien même actuellement, avec GRID et autres partenaires, nous sommes en train de capter cette variable au-delà des distances. S'il y a des ponts ou bien des îles, nous captons ces données en routine. Ici, c'est par rapport au traitement, aux échecs thérapeutiques. C'est une donnée des routines que nous utilisons, pas des routines, mais chaque 2 ans, nous faisons des tests d'efficacité thérapeutique dans le site Sentinelle. Nous avons invité aussi cette variable. C'est aussi la clearance aussi des Plasmodium falciparum, nous avons capté. Et finalement, c'est les marqueurs de résistance, comme vous le savez, marqueurs de résistance avec le gène K13 qui a été identifié récemment dans notre pays et les molécules, donc les marqueurs de résistance qui ont aussi été identifiés à partir de 2018 dans les tests d'efficacité thérapeutique. Nous les avons invités aussi à cet exercice. Et enfin, on continue encore. La résistance aux insecticides, c'est une donnée que nous captons en routine par rapport au site, à certaines recherches que nous faisons avec les partenaires, avec différents partenaires, avec PMI surtout. Nous avons une base de données considérable et ce sont donc des données récentes de 2023, comme vous le voyez. Même les plus vieux. Alors, après tout cela, après avoir capté tout cela, nous avons essayé de prioriser. Nous sommes partis dans la priorisation, nous sommes partis du milieu urbain, milieu rural, comme vous allez le voir tout à l'heure. Juste quelques minutes. OK. Bon. OK. Donc, nous partons milieu urbain, milieu rural. Le milieu urbain, nous le considérons comme un milieu à faible risque dans notre raisonnement, ce qui est vrai. Et les milieux ruraux, nous les considérons comme un milieu à haut risque. Et donc, milieu urbain, c'est à faible priorité. Priorité numéro 5. Ne suivez pas les chiffres. Priorité numéro 1, c'est haute priorité. Priorité numéro 5, c'est faible priorité dans notre nomenclature. Et donc, priorité numéro rural, c'est haute priorité. Dans les rurales, nous voyons est-ce que c'est à risque. Rural, nous contrôlons aussi est-ce qu'il y a des mouvements de population, PDI, c'est déplacement interne. Est-ce qu'il y a des populations déplacées en interne? Parce que ces populations déplacées en interne, c'est une population à risque. Si c'est donc milieu rural est à risque, alors c'est risque élevé. Élevé pour nous, c'est 1 ou bien 2, ou bien il peut être risque élevé numéro 3, ou bien il peut être modéré, ou bien c'est non. Et si la population, il y a des populations déplacées internes, si c'est non, nous laissons, il n'y a pas de population interne, nous ne considérons pas. Et s'il y a des déplacés internes, c'est une autre priorité, c'est pour cela que la priorité devient 2. Ainsi de suite, nous avons raisonné comme ça jusqu'à l'accès des soins pour prioriser, l'accès des soins pour prioriser, et par rapport à la parasitémie aussi asymptomatique, nous avons priorisé, donc nous avons, en fin de compte, nous avons eu Nous avons eu 5 zones prioritaires. Donc, la majorité, pas la majorité, à peu près 25% à 28% des zones étaient en priorité 1A. Priorité 1B, c'était 69 zones. Priorité 2A, autant de zones de santé. Et vous voyez que priorité 1 et 2, c'était presque plus de la moitié des zones étaient dans priorité 1 et 2. Donc, ce sont des zones hautement prioritaires. La priorité 5, c'était à peu près 69. 69, c'est à peu près moins de 10%, 8% des zones, moins de 10% de nos zones qui étaient à priorité 5. Donc, sur les 519 zones de santé. Alors, à la fin, les économistes de la santé sont venus parce que là, c'était des épidémiologistes qui raisonnaient. Les épidémiologistes se sont arrêtés là et se sont tournés vers les bailleurs. Les bailleurs, c'est PMI, c'est AMF, c'est les Fonds mondiaux. Nous disons, nous les épidémiologistes, nous avons raisonné et il y a ça. Maintenant, c'est l'argent. Il faut discuter, il faut prioriser. Quelle stratégie utiliser? Alors, ici, je vous rappelle que les fonds qui sont disponibles, c'est 228 millions de dollars américains qui sont disponibles. Si nous décidons de faire ce que nous faisons d'habitude, ça veut dire la couverture universelle, elle va nous coûter 373 millions de dollars universels. Donc, nous allons partout, comme nous le faisons d'habitude, dans les 519 districts. Ça fait 373 millions de dollars. Ça, c'est la possibilité 1, mais on doit l'abandonner parce qu'on n'a pas l'argent. On n'a que 228 millions annoncés et sécurisés. Alors, nous nous disons, nous avons 26 provinces en RDC. Est-ce que shall we drop some provinces comme les provinces hautement urbaines comme Kinshasa? Ça représente quand même 15 millions d'habitants. C'est une province aussi HBHI. Nous avons 10 provinces HBHI au Congo. Est-ce que we drop Kinshasa and the sudden Lubumbashi we drop? Alors, continuons à discuter. Nous disons, avec cette approche, 6 provinces seront abandonnées. 6 provinces qui représentent à peu près 35 à 40 millions d'habitants. C'est la Guinée, fois 3. C'est la population de Guinée fois 3. Nous les abandonnons parce qu'on n'a pas d'argent, on ne décide pas. Alors, finalement, nous disons, cette approche va nous amener des problèmes avec les politiciens. Vous savez, les députés nationaux, they will say, they will ask to the minister, pourquoi est-ce que vous avez abandonné notre province? Si vous avez 20 députés, 45 députés, 6 provinces, ça peut faire 150 députés contre vous. So, the minister will be chased. Donc, nous discutons avec les bailleurs de fonds et les stratèges politiques. Les stratèges politiques disent, cette approche va vous apporter des problèmes. Abandonnez-la. Parce que allons vers l'approche zonale. Ça, c'est l'approche provinciale. Finalement, on a fait un zoom. On a vu sur l'étendue nationale quelles sont les provinces qui posent problème et tout en excluant les grandes villes des provinces. C'est ainsi que cette stratégie a été retenue avec 228 millions de dollars. Elle va prendre 374 zones de santé, Health Districts, sur les 519. Et donc, on va abandonner à peu près 145 districts sanitaires qui vont être abandonnés et autant de millions d'habitants. C'est la stratégie actuellement que nous avons décidé d'expérimenter une année seulement, en 2024, l'évaluer si c'est possible. Entre-temps, nous allons continuer les plaidoyers. C'est pour cela que je suis venu ici pour faire les plaidoyers. J'ai vu GiveWell, j'ai vu AMF, j'ai vu même Fonds mondial. Malheureusement, le management supérieur du Fonds mondial n'est pas là. PMI a délégué quelqu'un de BOT. Il est en train de m'entendre. Alors, ma petite conclusion. Le budget est réduit de 62%. C'est un problème. Et le gap, vous l'avez vu avec moi, le gap persiste. Il est énorme. Nous avons sollicité AMF pour que l'AMF puisse lever des fonds complémentaires pour que la couverture demeure universelle. Comme vous avez vu, le nombre de cas qui ne fait qu'augmenter et les décès sont énormes. Donc, on a besoin de fonds. L'approche zonale a été retenue pour 2024, mais elle est délicate parce qu'il y a des zones qu'on va abandonner. Il faut un plaidoyer. Cette approche est sujette à discussion parce qu'il y a l'équité, la couverture universelle qu'elle remet en cause, cette approche. Elle remet en cause l'équité entre populations, entre provinces, entre territoires, entre zones de santé, entre districts, elle les remet en cause. Et la couverture universelle, c'est pour la couverture universelle comme nous sommes ici, à moins que Marcy puisse me dire que finalement l'AMP n'a pas la couverture universelle de couverture universelle de moustiquaires dans les politiques de l'AMP ou bien des RBM qui est ici représenté par Michael, son CEO. Donc, c'est un problème. Il y a plus de 50 millions d'habitants qui sont exclus dans l'équité. Il y a des provinces, beaucoup de provinces, Eastern Congo, avec beaucoup de déplacés. Qu'est-ce que nous allons faire comme acte? Avec des déplacés internes par millions d'habitants. Je vous livre ce que nous voulons faire. Nous voulons organiser dans les camps de déplacés, faire une approche qui est annoncée par couchette, parce que dans une tente de déplacés, je ne pense pas qu'on peut installer des moustiquaires imprégnés. C'est une moustiquaire imprégnée qu'on peut installer. Alors, quand vous distribuez la moustiquaire imprégnée chez les déplacés sont dans des aires de santé, sont dans des districts sanitaires. Qu'est-ce que vous faites de ces districts sanitaires? Vous donnez ce mot déplacé, c'est une politique que l'HCR déconseille. Quand vous êtes dans un village, vous donnez quelque chose aux réfugiés, il faut chercher quelque chose à donner en compensation aux gens, aux populations qui les ont accueillis. Donc, nous sommes en train d'entrevoir quelle stratégie. Entre-temps, il nous faudrait assurer la permanence de la routine, la moustiquaire que nous donnons à travers la consultation préscolaire, la moustiquaire que nous donnons à travers l'antenatal clinique. Il faudrait que nous nous assurons que là, il n'y aura pas de rupture de stock et qu'il y aura continuité dans les zones qui ne vont pas bénéficier, dans les provinces qui ne vont pas bénéficier de la distribution des moustiquaires. Et donc, il y a des efforts à fournir par rapport à ça. Entre-temps, il faut continuer avec les plaidoyers. Je l'ai fait aujourd'hui. Mais les plaidoyers aussi, internal advocacy, il faudrait un plaidoyer interne vers les provinces, vers les districts qui ne vont pas bénéficier, les expliquer, les faire comprendre pour que les politiques et les populations comprennent le bien fondé de cette approche que nous allons implémenter cette année. Et nous avons commencé tous la moustiquaire en RDC il y a 21 ans, bien 22 ans, c'était le social marketing. Le social marketing, nous l'avons enterré. Je pense que pour les villes, il faut reprendre le social marketing parce qu'il y a des gens en ville qui peuvent acheter la moustiquaire imprégnée et qui achètent la moustiquaire imprégnée, nous les voyons tous, qui ont besoin de la moustiquaire imprégnée, qui la cherchent, qui en ont besoin. Ceux-là qui en ont besoin, qui peuvent avoir l'argent, il faudrait que cette moustiquaire de qualité soit disponible. J'ai dit, je vous remercie.
Okay, we'll have in the interest of time, TM.
Donc, merci. Donc, c'est Dr. Serigne Amdi Thiam. Je suis du programme national de lutte contre le paludisme du Sénégal. Donc, j'ai l'honneur de partager avec vous donc, la priorisation de la lutte antivectorielle face aux ressources limitées donc, pour le Sénégal. Donc, le plan que nous allons partager, d'abord, c'est la présentation du pays avec les nombres de régions et les districts. les objectifs du plan stratégique 2021-2025, la situation épidémiologique, la cartographie des interventions de lutte contre le paludisme. Donc, comment nous avons fait la priorisation des interventions de lutte antivectorielle et les défis de la lutte antivectorielle. Donc, pour la présentation, donc, là, c'est la carte du pays avec les limites, mais surtout la population en 2023, c'est 18 millions d'habitants. Nous avons 14 directions régionales de la santé, 79 districts. Nous avons également une évolution donc, du paludisme qui est saisonnière, mais surtout nous avons également ce qu'on appelle les populations à haut risque. Ce sont les populations donc, qui concentrent vraiment le fardeau du paludisme. Ce sont les transhumants, ce sont les orpailleurs, mais également les enfants qui sont dans les écoles coraniques, que nous appelons les talibés. Nous avons des objectifs qui sont alignés aux objectifs de l'OMS, mais c'est de réduire la morbidité et la mortalité paludisme de 75%, mais également d'interrompre la transmission donc, locale du paludisme, parce que nous sommes dans une zone vraiment où la transmission est très, très faible. Nous avons des objectifs d'élimination d'ici 2030. Et la lutte antivectorielle est une stratégie majeure du programme, donc inscrit également dans le plan stratégique national. Nous mettons en œuvre essentiellement deux types d'interventions. La distribution des moustiquaires, mais également l'aspersion intradomiciliaire, mais de façon vraiment très, très ciblée. Donc, pour la situation épidémiologique, nous avons ici la carte de l'incidence. L'incidence avec la stratification que nous utilisons, une stratification opérationnelle. Ce qui est en vert, c'est le nombre de 5, si c'est moins de 5 cas pour 100 000 habitants, pour 1000 habitants. Donc, en jaune, c'est entre 5 et 15 cas pour 1000 habitants. Et en rouge, si c'est plus de 15 cas pour 1000 habitants. On voit que, donc, d'après la stratification que nous utilisons, donc c'est essentiellement dans la zone sud-est que nous avons une incidence plus élevée. C'est plus de 15 cas pour 1000. Si on utilise la stratification de l'OMS, là, on se rend compte que c'est essentiellement quelques districts du pays qui sont en situation où l'incidence, ce sont des zones de forte transmission. Donc, l'essentiel du pays donc, a une incidence donc, très faible, d'après la classification de l'OMS. Pour être très opérationnel, le pays a adopté une stratification vraiment très, très opérationnelle pour les districts. Donc là, c'est la stratification avec les ajustements. Le premier, c'est l'incidence brute sur la base des données disponibles, des données venant des structures sanitaires. Et on voit que c'est essentiellement la zone sud-est où nous avons la transmission qui est plus élevée. Avec l'ajustement sur le taux de dépistage à 100%, c'est toujours la zone sud et sud-est qui présente une incidence élevée. Troisième, c'est avec ajustement sur le taux de dépistage à 100%, couplé également au taux de complétude à 100%. Le dernier, c'est par rapport à l'incidence avec l'ajustement avec le taux, l'accès aux soins. Avec l'accès aux soins, on voit toujours cette zone-là qui constitue une zone où la transmission est plus élevée. C'est toujours la même zone. Donc, d'après la situation épidémiologique, donc, nous avons une répartition inégale donc, du paludisme suivant le pays, avec essentiellement la zone sud et sud-est où la transmission est plus élevée. Une zone de très faible transmission, c'est essentiellement la zone nord. La zone centre, c'est l'essentiel du pays, et la zone centre également, mais nous avons identifié des populations, donc suivant les catégories socio-professionnelles qui sont les plus exposées au paludisme. Pour la cartographie des interventions, nous mettons en œuvre, en fonction des zones, un certain nombre d'interventions. Et quel que soit le strate, nous mettons en œuvre des interventions de lutte antivectorielle. Donc, dans la zone nord, ce sont essentiellement des interventions visant donc l'élimination avec les investigations. La zone sud et sud-est, donc en plus de la distribution des moustiquaires de dernière génération, les moustiquaires PBO, de même que les moustiquaires duels, donc nous avions mis en œuvre donc l'AID de façon ciblée au niveau de certains districts. Dans la zone centre également, c'est la CPS en fonction de certaines zones, mais également nous mettrons en œuvre aussi la distribution des moustiquaires dans le cadre de la routine. Donc, pour les interventions, il y a la distribution d'utilisation des moustiquaires. Il y a l'aspersion intradomiciliaire qui est mise en œuvre dans certains districts suivant la particularité de certaines zones. La surveillance entomologique, mais également, nous avons mis en place des documents stratégiques. Donc, le plan de gestion de la résistance, les directives de gestion de la résistance, mais également, nous venons juste de réviser notre plan stratégique où la lutte antivectorielle représente 33% du budget du PSR. Et nous avons également des partenaires qui nous appuient par rapport à la lutte antivectorielle. Donc, pour les facteurs de priorisation, nous avons essentiellement 3 domaines. Donc, d'abord, c'est par rapport aux aspects épidémiologiques. Pour les aspects épidémiologiques, c'est l'intensité de la transmission, l'existence de populations à haut risque qui sont le plus souvent exposées au paludisme, mais également les cibles vulnérables qui sont les enfants de moins de 5 ans et les femmes enceintes. Mais également les facteurs entomologiques avec la résistance des vecteurs aux insecticides, parce que nous avons des sites sentinelles de surveillance, mais également le taux d'inoculation entomologique. Également le facteur financier, donc avec la diminution des ressources financières et le plan de mobilisation des ressources. Et pour chaque domaine, au niveau national, nous avons mis en place un document, un plan stratégique pour pouvoir compenser ces gaps qui ont été identifiés. Il y a le plan d'accélération vers l'élimination du paludisme, le plan de gestion de la résistance et pour la mobilisation des ressources, donc le plan de plaidoyer pour la mobilisation des ressources domestiques. La surveillance entomologique, nous avons beaucoup de sites sentinelles répartis dans presque tous les districts sanitaires. Nous avons 54 sites sentinelles de surveillance entomologique et qui montrent vraiment une bonne représentativité des sites sentinelles de surveillance. Donc, pour le taux d'inoculation entomologique, donc c'est essentiellement cette zone sud et sud-est que nous avons le taux d'inoculation entomo donc le plus élevé. Pour la zone nord et les autres zones, bien que nous avons des sites sentinelles, donc le taux d'inoculation est très faible. Pour le profil de la résistance, donc là, par rapport aux prutonéides, nous avons constaté une résistance généralisée, mais avec les PBO, nous avons constaté quand même une augmentation de la mortalité après l'exposition aux prutonéides. Ça veut dire qu'aujourd'hui, donc la résistance est contrecarrée par l'utilisation des PBO au niveau de l'ensemble des sites de surveillance. De la même façon également, donc par rapport à l'utilisation des moustiquaires de dernière génération et des AID également, nous avons constaté qu'il y a une sensibilité aux chlorothianidines, mais également donc aux autres insecticides qui sont souvent utilisés. Pour la surveillance entomologique, donc nous avons une sensibilité dans les sites sentinelles qui sont répartis au niveau des différentes stades. Et également, nous faisons la surveillance de l'Anopheles stephensi au niveau de certains sites bien définis. Il y a une résistance généralisée aux prutonéides qui est constatée, intensité de la résistance qui varie suivant les zones, qui a été vraiment notée, mais également une restauration donc, de la sensibilité avec l'utilisation des PBO, une sensibilité aux autres insecticides qui sont souvent utilisés, mais également au niveau de insensibilité totale au chlorphénapyr, mais également chlorothianidine. Donc, pour l'AID, la priorisation, donc au niveau national, donc pour l'AID, nous avons des AID en fonction de différentes zones. Donc, dans la zone nord, donc c'était de l'AID, aspersion intradomiciliaire, en ciblant les postes de santé, donc hotspot, les postes de santé où il y avait des cas de flambée. Et là, c'était tous les postes de santé qui étaient concernés. Donc là, c'était en 2021. En 2022, donc nous avons procédé à l'AID zone de flambée, en cas de flambée, dans le cadre des investigations, donc intégrées dans le paquet des investigations. Et aujourd'hui, dans le cadre de notre nouveau PSN, nous envisageons de faire des AID, donc en ciblant les zones qui ont des flambées de façon répétée. Donc l'AID, donc zone de flambée, mais de façon répétée. Et pour ce qui concerne l'AID intégrale, c'est essentiellement dans 4 districts de la zone sud et sud-est qui étaient mis en œuvre en 2021 et 2022. Mais depuis l'introduction des moustiquaires de dernière génération, nous avons arrêté les AID pour mettre en œuvre un plan de retrait de l'AID dans la zone donc, sud et sud-est. Donc, pour la campagne de 2022 et la campagne prévue en 2025, nous avons des éléments qui nous ont permis vraiment de faire la priorisation. Donc, pour la campagne de 2022, c'était dans 12 régions, donc avec la distribution des moustiquaires PBO, mais également les distributions de moustiquaires donc standard au niveau des zones où il n'y avait pas de résistance. Et pour la campagne qui est prévue en 2025, ce sera dans 8 régions et ça concerne les districts, les régions qui ont des incidences les plus élevées, mais avec les moustiquaires de type duel. Les éléments de paramétrage, c'était essentiellement le financement. Donc, nous avons constaté une diminution de près de 5% du financement entre la campagne de 2022 et la campagne qui est prévue en 2025. Mais également, nous avions l'opportunité de l'appui de certains partenaires. Pour l'autre élément, c'est le choix des régions. Le choix des régions, comme nous l'avons vu, on s'est basé sur donc, la situation épidémiologique, avec l'incidence, avec la prévalence, les résultats de la surveillance et le taux d'inoculation donc entomologique, mais aussi la faisabilité opérationnelle. Parce que pour la faisabilité opérationnelle, donc on s'est rendu compte que dans les zones urbaines, c'est très souvent difficile de mettre en œuvre la campagne de distribution de moustiquaires. Donc l'autre élément également, c'est dans la zone de sud-sud-est, de faire de sorte que ceinturer complètement cette zone-là pour qu'il n'y ait pas que la campagne soit dans l'ensemble des régions autour de la zone de sud-sud-est. L'autre élément, c'est le choix également des types de moustiquaires. Le choix des types de moustiquaires, c'est basé sur les résultats de la surveillance de la résistance. Et pour la campagne de 2022, c'était dans les 12 régions. Et la campagne de 2025, ce sera dans 8 régions. Et en mettant en œuvre cette campagne, donc, il va falloir trouver d'autres stratégies pour les zones qui ne seront pas concernées par cette campagne. Et c'est pourquoi nous avons pensé quand même renforcer la distribution des moustiquaires dans la distribution de routine, en ciblant les populations les plus exposées, aussi bien dans les zones où on met en œuvre la campagne que dans les zones où on ne met pas en œuvre la campagne. Ça permet quand même de compenser. Donc, le renforcement de la distribution des moustiquaires de routine sera renforcé dans l'ensemble des régions, surtout dans les régions qui ne vont pas faire la campagne en 2025. Les autres interventions, donc c'est la distribution continue qui va se dérouler dans les 14 régions. Donc, avec l'ensemble des canaux sanitaires, communautaires, avec les investigations dans la zone nord. Donc, lors des investigations, donc chaque fois qu'il y a des gaps de moustiquaires identifiés dans les maisons, dans les concessions, on comble gratuitement ces moustiquaires. La distribution dans la population générale, mais également la priorisation aux femmes enceintes, aux enfants de moins de 5 ans, mais aussi la distribution en ciblant les populations à haut risque qui sont essentiellement les élèves qui sont dans les écoles coraniques, les adolescentes, les jeunes et dans les zones également où les zones inondables. Et nous avons prévu également de mettre en œuvre ce qu'on appelle la surveillance donc de la résistance qui va continuer dans le cadre des défis. La surveillance de l'Anophel Stephensi avec l'université, la mise en place d'un plan de rotation. Parce qu'aujourd'hui, on passe des moustiquaires duels aux moustiquaires PBO. Donc, avec la surveillance, on pourra à tout moment revenir sur les autres types de moustiquaires. La mobilisation accrue des ressources avec le plan de mobilisation des ressources, mais également la distribution des moustiquaires en ciblant les populations les plus à risque de paludisme. Donc, je vous remercie de votre aimable attention.
Okay, thank you very much. We'll take 3 questions for the panel. That one. Last. Going once, going twice. Okay, 2 questions. So let's start with the lady, yes.
Thank you very much. Makuzike Tauzi Banda from Malawi. I had a question for the colleague from DRC. There was a mention of prioritization for that was urban versus the rural. I just wanted to find out what your plans are for the semi-urban. I believe that within the urban areas, there should be some pockets of semi-urban. And what are the interventions that you're planning for that component of the suburban? And if you have any intervention, would you kindly share those interventions? But also, I would want to find out what you are anticipating from leaving the urban out. What is your anticipation and how are you going to respond should you have that outcome? I'm asking this based on our experience in Malawi. During the net distribution, we had also prioritized and left out the urban area. But then we saw an increase of cases coming through the health facilities that were in the semi-urban component of the urban areas. So I just wanted to learn from you. Thank you.
Hi, I'm Marcy, for those of you who don't know me. I have sort of 2 comments or questions. So the first one really, Prof. Eric, I will never, ever tell you that what is happening in DRC is good. I will always argue that you need universal coverage as an HBHI country. So just to say, I think all of us in the room are advocating on your behalf, as we do know that you need more resources. One of the questions I had for you was you identified that you were using different strategies for your IDPs and your displaced people in the insecure zones. So I just wondered if you could talk a bit the differentiation between the strategies in a normal, quote unquote, area and in a displaced area. And then for Senegal, Dr. Thiam, thank you very much for the presentation. And my question for you is, for the last number of years, you've been working on cross-border initiatives with the Gambia. And with now the reduction and the stratification that's been done, how does that affect the work you've been doing for cross-border malaria control with your partners in the Gambia, given that some of your deprioritized areas seems to be on the border with the Gambia, which might be prioritized on the other side? Thank you.
Thank you for my sister from Malawi. I will reply in French. Bien, merci beaucoup pour votre question. C'est une préoccupation qui est la nôtre. Comme vous le savez, arriver à exclure certaines zones parce qu'elles sont urbaines, c'était une décision très difficile. Très difficile. Je suis aussi d'accord avec vous quand vous dites qu'il y a des périurbains. C'est vrai que dans toutes les villes africaines, il y a toujours eu des périurbains. Mais nous avons utilisé en statistique, on appelle ça binary. donc des variables binaires. Donc, oui ou non. Il y a des conséquences pour ça. Mais l'exercice continue. L'exercice continue pourquoi? Parce que nous n'avons jamais terminé la stratification des grandes villes. Les grandes villes de la RDC, on n'a jamais terminé la micro-stratification des grandes villes. On a l'idée. Et donc, on pourrait peut-être les récupérer s'il y a des ressources supplémentaires que nous arrivons à mobiliser. Nous pouvons récupérer les zones périurbaines de certaines grandes villes. C'est une réflexion qui reste ouverte et nous continuons à chercher des solutions quant à ce, par rapport aux semi-urbains qui sont dans nos villes. Donc, si nous avons des ressources supplémentaires, nous allons les prioriser, nous allons finaliser avec la microstratification des grandes villes, qui est un travail en cours avec l'OMS, avec Galatas et tous les autres, les PAT. Nous allons finaliser et nous pourrons récupérer certaines zones. Au-delà des périurbains, ce que vous n'avez pas dit, c'est que dans les grandes villes, donc grandes villes comme Kinshasa, souvent, c'est plus la nuisance. Nous avons la surveillance entomologique. La surveillance entomologique qui nous guide nous informe que la plupart du temps, ce sont des culex urbains. Ce ne sont pas des anophèles. Ce sont des culex urbains qui sont là pour la nuisance. Même quand bien même ils utilisent la moustiquaire, c'est pour éviter cette nuisance des culex. Ça, c'est l'information entomologique que nous avons à partir de la ville, des villes comme Kinshasa. Donc, nous sommes suffisamment informés, même si nous n'avons pas de ressources et que nous voulons un peu les abandonner. Merci, j'ai dit grandement merci. Comme c'est toujours ta préoccupation de voir la couverture universelle continuer. Nous sommes ici, nous comptons aussi sur vous pour les plaidoyers pour la RDC et je suis convaincu que vous allez continuer à faire les plaidoyers pour le pays. Pour les déplacés internes de la RDC, on n'a pas encore de décision finale. Nous venons de Kinshasa avec tous les bailleurs, nous avons discuté, nous avons juste dit que nous pouvons faire ce que nous avons dit, mais il faudrait que nous puissions nous rapprocher. Nous allons aller à l'est du Congo, écouter la province, écouter ces zones et finalement définir quelle est la stratégie que nous allons faire. Donc, aussitôt que nous rentrons à Kinshasa, nous allons effectuer un voyage. Malheureusement, les collègues de l'AMF et les collègues du Fonds mondial ne veulent pas aller à l'Est. Ils n'ont pas de clearance for security matter. Ils n'ont pas de clearance. Ils m'ont délégué que ce que je vais dire, on va faire. Ce que les gens de l'Est vont dire, nous allons le faire ensemble. Merci.
Donc, merci pour cette question par rapport aux initiatives transfrontalières avec la Gambie. Donc, dans le cadre de l'élaboration de cette demande de subvention, nous avons toujours maintenu donc, la synchronisation de la campagne avec la Gambie. Donc, aujourd'hui, donc, toutes les régions qui sont frontalières avec la Gambie ou les districts, donc la campagne sera mise en œuvre. Je pense que là aussi, c'est important de le préciser. L'autre élément également, nous avons tenu compte également de ceinturer toute la zone où l'incidence est plus élevée. Ce sont les trois régions. Donc, au-delà même de cette campagne, les initiatives donc, transfrontalières donc, seront renforcées donc, aussi bien avec la Gambie qu'avec les autres pays. Avec l'appui de l'OMS, nous avons tenu donc, un atelier donc, au Sénégal pour voir comment on peut travailler ensemble pour renforcer les interventions au niveau de l'ensemble des pays qui sont limitrophes. Mais au Sénégal, rappelez que c'est essentiellement des interventions de préélimination qui sont mises en œuvre dans la zone nord. Là où on ne met pas la campagne, nous avons même prévu de renforcer la distribution de moustiquaires en ciblant les populations qui sont les plus exposées. Donc, merci.
Okay, enough. I think we can continue discussions with colleagues over coffee and after the session. Is there one burning question? Only one. Okay.
Ok, merci. Moi, c'est Dr Kamara Tipoura du Burkina Faso. Merci pour les présentations. Je vais juste m'adresser à Dr Thiam du Sénégal, étant donné que le Sénégal est très avancé dans le cadre de l'élimination du paludisme et que le Burkina espère aussi l'atteindre dans quelques années. La première question concerne la surveillance entomologique. Étant donné que vous avez jusqu'à 54 sites sentinelles et que vous avez réussi à utiliser le taux d'inoculation entomologique parmi les critères de priorisation, j'aimerais que vous partagiez votre expérience de surveillance entomologique. Parlez-nous des acteurs qui font la collecte des données et dans quelle régularité ces données sont collectées. Je suis curieux en fait de savoir qu'est-ce qui est fait dans le cadre de la surveillance entomologique pour que vous ayez régulièrement les données des 54 sites entomologiques. Une deuxième question, vous avez beaucoup insisté sur les 4 régions qui ne vont pas faire la distribution des MILDA en 2025 en disant que vous allez renforcer la distribution des routines. Qu'est-ce que vous allez faire exactement? C'est ce qu'on a envie de savoir. Les cibles concernées, est-ce seulement les enfants, les femmes enceintes? Est-ce qu'il y a d'autres cibles pour la distribution des routines et comment vous allez faire pour améliorer les couvertures chez ces cibles-là exactement? Voilà, si vous pouvez nous partager les expériences. Merci.
Donc, merci. Donc, pour ce qui concerne la surveillance entomologique, donc, il faut savoir qu'au niveau national, au niveau du programme, on est appuyé par PMI. Donc, c'est à travers le projet Evolve qu'ils font la surveillance entomologique. Et ils travaillent en étroite collaboration avec les universitaires. Donc, ce sont les universitaires avec une équipe bien fournie, donc appuyée par l'équipe du programme. Il y a une planification des sites qui doivent être visités et que régulièrement, donc, ils descendent sur le terrain pour faire la collecte. Et au-delà même de la surveillance que les équipes font, il y a ce qu'on appelle la surveillance entomo au niveau communautaire. Donc, il y a les acteurs communautaires donc, qui ont été formés, qui font également la surveillance entomologique. Donc, les données sont collectées sous la supervision de l'équipe du programme, mais également l'équipe de l'université, c'est le laboratoire d'écologie vectorielle et parasitaire. Donc, ce qui fait que vraiment, bien que nous avons un bon nombre de sites de surveillance entomologique, donc les données sont collectées parce qu'il y a un bon dispositif de surveillance qui existe. Donc, pour l'autre élément, pour les régions qui ne font pas la campagne, donc c'était un peu difficile quand même de faire la priorisation. Comme nous l'avons vu, il y avait une diminution des ressources entre le GC7 et le GC6. Il fallait quand même trouver des stratégies pour pouvoir identifier. Nous avons mis en place l'ensemble des régions, les 14 régions, il y aura la distribution des moustiquaires de routine. Mais ce sera cette fois-ci une distribution avec un plan de renforcement de la distribution. Donc, nous avons prévu d'abord d'identifier toutes les populations à haut risque parce que nous avons, avec l'appui de RPM, donc, fait l'évaluation du malaria Maxbox qui nous a permis d'identifier donc, les populations à haut risque. Donc, nous avons les camionneurs, nous avons les transhumants, nous avons les orpailleurs. Donc, ces populations ont bien été identifiées. Et nous allons continuer à faire l'identification de façon détaillée de ces populations. Et dans le cadre de la demande de subvention, nous avons prévu une distribution ciblée de ces populations, c'est-à-dire une distribution gratuite de moustiquaires. Nous avons même commencé avec PMI en donnant gratuitement les moustiquaires aux talibés, les élèves qui sont dans les écoles coraniques, en distribution gratuite. Parce que les résultats que nous avons à travers l'analyse des données, des investigations montrent que ce sont ces élèves talibés qui sont le plus porteurs de paludisme. Donc, ce sont ces distributions ciblées qui seront effectuées. Mais en plus aussi, donc, c'est le marketing social au niveau des grandes villes. Donc, on sait qu'à Dakar, la distribution de moustiquaires, souvent, c'est pas communautaire. La distribution en campagne, c'est pas souvent évident. Donc, c'est pourquoi on va faire la promotion donc, du marketing social, donc avec à travers les grandes surfaces, que les moustiquaires vraiment soient disponibles. Mais l'autre élément aussi, la distribution qui cible les ados et les jeunes. Donc, les résultats montrent aujourd'hui que ce sont les ados, les adolescents et les jeunes qui également constituent une cible donc, de plus en plus vulnérable. Donc, nous allons travailler avec les centres conseils ados parce qu'au niveau national, nous avons des espaces ados où les jeunes se rencontrent régulièrement. Nous allons travailler en étroite collaboration avec les responsables de ces centres conseils ados pour que quand même les moustiquaires soient disponibles et que ces moustiquaires soient distribués donc, à cette cible-là. Donc, il y a beaucoup d'autres stratégies que nous avons commencé à mettre en œuvre qui seront poursuivies donc, durant l'année 2024 et durant l'année 2025. Merci.
So can I start by actually asking you to clap for our two colleagues who are presented? So I think we've learned a little bit about this theme around key populations, IDPs, yes, and IDPs, and definitely what is happening in Senegal. So we'll break for coffee and we'll come back and dive a little bit more into urban areas and urban microcertification and learning lessons from Guinea and so on. So thank you very much. We'll start on time. This time I'll be very strict on time. So 14, past. We start at past. Thank you. Settle down and start. I think our first presentation, is it online? Is it online? The first So we would like to welcome Dr. Ifuma from Loyola University. This session is, as I said, will be around urban and prioritization. So Ifuma, please welcome, and can you take it away?
Sure, can you hear me?
Excuse me, colleagues, those of us who are still having conversation, we would like to start, please. Thank you. Take it away, Ifuma.
Thank you. So my talk today, it's really to explain the approach that we took to the prioritization of bed nets during the recent mass campaign in Ilorin, Kwara State. Ilorin is the capital city of Kwara State. And this framework that that was applied for the prioritization of bed nets was co-designed with stakeholders. To sort of set the stage for why this was important to do, and I think, and as alluded by various presentations earlier, it's important to point out that a lot of malaria endemic countries are rapidly urbanizing. And I think that the conversation about urbanization is a conversation for the future. For instance, in Nigeria, currently, over nearly 60% of the population live in urban areas. And in 2050, it's expected that most malaria endemic countries in sub-Saharan Africa will be urban areas. And so what does this mean for malaria transmission, given that there is increasing population growth? It is likely that the burden of malaria transmission would shift from rural to urban areas. But presently, the current approaches for malaria control are typically based off of rural areas and really focus mostly on rural areas. And a number of speakers have also highlighted the importance of having a different approach in urban areas. And some of the reasons why this is important is because the transmission dynamics are different. There are differences in health-seeking behaviors, differences in determinants, as well as differences in acceptability and use of bed nets or other vector control tools. So to sort of highlight what the implications of these differences are, I have this, picture here or graphic here to illustrate some of these differences and what they mean for the approach we take to malaria control in urban areas. So, for instance, for disease distribution, we know from the literature that transmission is mostly focal in urban areas. It's mostly concentrated in peri-urban settlements and informal settlements. And I think there was someone that just mentioned about how deprioritizing bed nets in urban areas without taking into account the transmission in peri-urban areas led to a resurgence of malaria transmission. And what this means is that we really need to take a targeted approach, both to surveillance and intervention delivery, making sure that those at highest risk of transmission in urban settlements are targeted. There's also the issue of, the source of infection. It's likely that in many urban areas, the source of infection is linked to travel to and from rural areas, which typically would have the higher transmission and higher risk. But, so while you would see, for instance, in rural areas that most infections are locally acquired. And knowing that for many urban areas, people often travel either for work or for celebrations during the celebration period, maybe during Christmas, this could also have implications for the seasonality of infections in urban areas. There's also the question of the issue of housing types. In urban areas, a lot of the houses may actually reduce indoor biting, and you're having most exposure occurring outside the homes. And this could also have implications for whether bed nets will really be useful in many urban areas. And then the last point I want to highlight is the issue of aquatic habitats. There might be differences in aquatic habitats in urban areas versus rural areas. In urban areas, there are more anthropogenic habitats, typically driven by human activity. And for instance, a number of people have also pointed out the issue of Anopheles stephensi, which is adapted to urban settlements. So the WHO really has provided us with a guideline or a building block to focus the response for urban areas. This is from the global framework that was just released for addressing or developing a response for addressing transmission in urban areas. And you will see that this building block highlights the importance of urban leadership as well as community engagement. And also, more importantly, is the fact that we have to actually develop good surveillance systems that enable us to collect the kinds of data that is needed to respond to malaria in these urban settlements. We'll need different kinds of data to understand how to develop a much more targeted approach, something that an approach that actually follows something similar to what Bayer had presented on subnational tailoring of interventions. So we'll need both entomological data, we'll need epidemiological data on transmission, we'll need data on interventions, we'll also need to understand mobility and demographics, climate and how other environmental factors affect transmission. And we also want to understand socioeconomic determinants. And as Bayer had described, if all this data is collected, typically we should be able to develop a tailored approach to interventions to urban settlements, focusing on the interventions that the WHO has recommended for controlling malaria in urban areas. So things like environmental management, chemical and microbial control, chemo prevention, vaccine, and behavioral change. But unfortunately, a lot of countries actually lack the data for prioritization. And currently, many countries want to optimize bed nets, as has been seen from the various presentations. And my team, what we've been doing is working with Nigeria and more recently Côte d'Ivoire to co-create a framework on how to optimize bed net distribution in cities, even in the midst of the data poverty that we're currently experiencing. So in the context of my presentation, when I say deprioritization, the idea is really to distinguish the least vulnerable population from other vulnerable population. So on the continuum of vulnerability, who is least likely to be affected by malaria. And thinking about this, there are observable characteristics that can help us out. We already know that housing is a key factor, and that transmission in urban settlements are environmentally driven. So can we identify these observable characteristics working with the communities and use those characteristics to classify areas according to levels of vulnerability, taking into account that we might not have a perfect classification, but we could typically identify those that are most vulnerable or least vulnerable. And then the difference with prioritization, which I think a lot of people have discussed and pointed out, is that you require a lot of data to do that. You really want to be able to compare and classify communities or rank communities by the level of malaria risk. And that is very difficult to do when you don't have the kinds of data, the granular scale that is required for that. So the approach that we developed as part of this work together with stakeholders in Nigeria, I think falls into 6 brackets or buckets. So first of all, the NMCP and the urban leadership would work together to determine what the deprioritization criteria would look like. Then there is afterwards some data assembly and analysis, as well as mapping to characterize malaria risk at the smallest administrative unit using whatever data is available. And following that, due to data limitations, it's important to have some form of validation or community validation of the malaria risk map and data quality assessment. And then the next step after that would be to then collect supplementary data to enable classification of communities according to characteristics, observable characteristics. In this case, what we did was to identify the characteristics of different settlement types in urban areas and classify them into formal, informal settlements and slums. And then finally, reviewing all the maps and data together and deciding which communities to deprioritize or exclude during the BedNet campaigns or during intervention delivery. So this, I'm going to then describe for you how this approach was applied in Ilorin. Ilorin really was the inspiration for this approach that we came up with. And this campaign happened last year. The Nigerian NMCP wanted to deprioritize nets in Ilorin, given that in Kwara State, it was a reported 6%. Malaria prevalence was reported at 6% based on the 2021 MIS amongst children under the age of 5. There was a funding constraint. I think it was about 80-20. So the 20% based off of the previous funds, 20% of nets of the funding from the previous campaign was going to be reduced. So they were going to only get 80% of what they anticipated in terms of funding. There was no baseline survey, so we just didn't really have any recent micro level data to guide this work. And we had a 2-week timeline to come up with this approach. So this really we had to come up with in a very, very short time. The map that I'm showing you on the right side is the map of Ilorin, which has 3, and I put in quotes urban because these areas were designated as urban, but we also had to determine what the urban extent was actually for these areas. So how did we approach this? My group has been doing a lot of work in Nigeria, conducting field studies to understand malaria transmission in cities. We are focused on 2 cities, Kano, which is in Kano State, and we also have Ibadan, which is in Oyo State. Kano is in the northern part of Nigeria, Ibadan is in the southern part of Nigeria. And preliminary findings from these studies sort of highlighted the fact that is also present in the literature and served as evidence to suggest that the burden of malaria is much higher in slums and informal settlements. And when you can identify what these settlement types and their characteristics look like by working with communities, you can actually be able to determine which areas might likely have the least lower vulnerability or to transmission. So what I'm showing you here is the data that we collected from our work on the left side from Ibadan. So we worked with stakeholders in Ibadan to identify what the characteristics of formal settlements were, informal settlements and slums. And then we went to these communities and we did RDTs, and this was preliminary findings with regards to those that tested positive. And then on the right side, this is what the classification of the wards, which is the lowest administrative units, would look like when we classify them using the criteria that we developed with the members of the community. So taking this understanding and knowing that the risk is much higher amongst those in peri-urban areas or slums or informal settlements, we decided to, given the limited time that we had, to identify communities that had characteristics of slums and informal settlements, and also identify those that had the characteristics of formal settlements, and then use that as a way to guide how we approached deprioritizing areas. So our process was, first of all, you can see the map of Ilorin below. We started by first ranking all the wards by levels of malaria risk. And then we validated and co-designed with the subsequent process with the community. And this is the NMCP, various implementing partners, the State Ministry of Health. And then finally, we classified communities which were within the microplan. And then according to whether they were formal settlements, informal settlements, and slums. And working with the program then selected which areas to deprioritize. So what did the ranking of wards by level of malaria risk look like in a context of limited data? So what we did was to gather as much data as was available to us. Some of the data that we used was, for instance, the proportion of neighborhood blocks with poor quality housing, which we obtained from the Bill & Melinda Gates Foundation based on a project that was done in previous years. We had data on enhanced vegetation index in 2020. We also had data on the distance to water bodies. We took the routine data on test positivity rates from 2014 to 2021 that was collected at the health facility level and aggregated it up to the ward level. We weren't sure if this was representative or not, which was why we also wanted to do some community validation. We then combined these indicators to generate several maps of malaria risk to account for uncertainty, given that we didn't really understand what the distribution of risk really was. So this is what some of the maps would look like. So for instance, on the left side, you're seeing a map that is a combination of test positivity rates and the proportion of neighborhood blocks with poor quality housing. And then on the right, you're seeing a map that is a combination of distance to water bodies and proportion of neighborhood blocks with poor quality housing. So the next stage was we took these maps, we developed nearly over 10 of them, and then we sat down with the NMCP, the State Ministry of Health, various local people and implementing partners. I think we also had someone from the Ministry of Environment. And we asked them to help us to validate the data or do some data quality assessments. We organized a multi-stakeholder dialogue about 3 hours to guide decisions on the following. So we wanted to determine what was the most appropriate data set to help us classify wards by levels of malaria risk. We wanted to then finally select the map based off of what the local understanding of malaria risk was, and to enable us identify which wards have the highest and lowest malaria risk according to local understanding. And then we also wanted to determine what should we do next. Is it okay to do deprioritization at the ward scale, or should we go lower than that? And then if the idea is to go lower than that, then we also need to start thinking about applying the framework of determining the characteristics of different communities. So determining the characteristics of formal settlements, informal settlements, and slums for Ilorin in this case. And then we created a checklist as part of the dialogue to classify settlements, classify communities by settlement type. So at the end of the multi-stakeholder dialogue, participants chose this map that you're seeing on the left side or the right side of the screen. According to them, this was the combination of data that included, or data combination that included death positivity rates, proportion of neighborhood blocks with poor quality housing, was the one that most represented the malaria risk according to their local understanding. So the first two highest ranked wards, so the areas numbered 1 and 2, were areas that were selected for where deprioritization activities would be conducted. Participants also noted that you cannot deprioritize entire wards because of heterogeneities in living conditions even within the wards. So we then asked them to tell us how can we characterize formal settlements, informal settlements, slums, and even rural areas. Are there particularly areas that are rural in the so-called urban axis of Ilorin? And this here is a summary of some of the key themes that emerged on what the key characteristics of these areas. So for formal settlements, for instance, there was emphasis on structure. So the layout of buildings or dwellings were well structured. They typically had hospitals and basic amenities. There was also the fact that there was some kind of government oversight in these areas. In slums, it was the opposite was the case. They highlighted the issue of poorly structured. There was no basic amenities, and same with informal settlements as well. So then we took the teams, and we had already developed a checklist from our previous work that we used to classify areas in both Ibadan and Kano where we were working. And so we took what they told us about the characteristics of areas and tried to update or adapt the existing checklist to be relevant to the Ilorin context. We then went to the state ourselves, and our team then worked with the State Ministry of Health to pre-test and update the settlement checklist after the multi-stakeholder dialogue. We did this, for instance, individuals that doing the training told us that a lot of people or dwellings that can be termed formal settlements typically have like water storage tanks, and mostly the rich could afford that, as well as boreholes. So that was also included in our checklist for classification. So we trained the state MOH on how to classify communities using the checklist. We asked them to take as many pictures as possible. And then they also took the coordinates of these areas as part of their data collection. In 2 days, they visited 188 communities and classified them, as well as collected their coordinates. So these were the 2 communities that were selected for wards that were selected for deprioritization activities. And what I show you here is how the outcomes of the classification process. So 73 communities were visited in Aretu, which is one of the communities, and 115 communities were visited in Akambi 4. So what I have circled in red are the areas that were then deprioritized, because after the data was collected, the program and the state MOH and as well as other partners sat down and had to make a decision on where they would deprioritize. And they decided that they wanted to deprioritize areas where there was a clustering of formal settlements. So if you see, these were circled, these 2 circles represent the areas that were deprioritized. The other areas that had formal settlements were not deprioritized, either because they were too close to slums and informal settlements, or they were too close to water bodies as well. So these are pictures from the field of what we gathered, from the data we gathered of what formal settlements look like in the different wards, pictures of informal settlements. And we also found a rural style settlement as well within the axis of areas that were termed urban. So what should you take away from this? I think national programs can maximize, they want to maximize the resources they have by optimizing delivery of interventions in urban areas to account for risk and need. But in order to do that, we need a really strong surveillance system that captures data on burden and determinants at a granular level to do this well, and to ensure that we can have a rigorous micro planning process that prioritizes those at highest risk. Initially, of course, this data will be very challenging to collect and may be expensive, but in the long run, it might pay off, because then you'll be able to much better target interventions to those that need it the most. Unfortunately, most countries lack the needed data. We're showing how this can be done in a data poor environment, but I think there could be improvements to this process so that it can follow a much more rigorous process like Bea had described. And I think as countries urbanize, it will be imperative to understand the impact of urbanization on the patterns and magnitude of transmission, as this is essential to facilitate progress towards elimination. So in terms of next steps for us, we have developed a process and we want this, countries to be able to use this process easily or adopt this process easily. And we have developed a malaria risk mapping tool that we are currently working on workshopping with the Nigeria Malaria Elimination Program. Hopefully that can be used in other urban areas and would require less assistance from our team and can also, that would ensure, of course, that it's much more locally driven. So this is all I have for today, and thank you all for inviting me to present.
Before we go to the questions, we'll do Elena. Dr. Elena, is she? Yeah.
There you go. Can you hear me? Cool. Great. So I'm going to be presenting some more about the ITN deprioritization in Kwara. And I don't know, do I have slides? I can just talk. That's fine too. So I'll start by saying that, so I'm with Crop Health. We've been providing some technical assistance to the NMEP in Nigeria on the piloting of this ITN deprioritization in Kwara. And so just to emphasize that while I am the one standing up here, I'm presenting on behalf of a big team, including the NMEP and the SMEP in Kwara. So just wanted to make that statement up front. So I think we can get into it now that I have slides. Very exciting. Can I move my slides? Yep, great. So the previous speaker has made my job very easy for the background. She's already given the rationale for ITN deprioritization in general in urban areas, and in particular in Kwara, and walked you through the process for selecting the settlements that were selected for ITN deprioritization. And then now what I'm going to talk about is how that process actually went. So how the campaign happened in these settlements where deprioritization was done, and then also a household survey that we did after the fact, both in the deprioritized settlements and then also in some similar nearby settlements that did receive ITNs. So just to position yourself again, that doesn't work. We're in the dark green. So it's an area that was a combined SMC and door-to-door ITN campaign in an urban area. Great. So basically, we had two components to this evaluation. We had observation activity. So this was done in the planning, in the training, and in the distribution phase of the activity. And then we had a household survey at the end where we went back into the community and did some questionnaires with some households in those communities. Just a brief timeline, see how that color came out, not very well. So we started in September with updating training materials. So primarily the training manual used in preparing for the campaign. Then October was the training activities and the actual distribution, and then also an after action review meeting that our observation team attended. And then we had the household survey in December. So start just a little bit of information about how the training materials were amended to reflect the changes from ITN deprioritization. So a few main points that were taken into consideration in these edits. First was an explanation of ITN deprioritization. So the same explanation that you've just heard about why to do it and which areas were going to be affected by this change. Then a reminder to account for the deprioritized settlements when taking into account the daily targets for ITN distribution in these areas. Highlighting some elements of the household visit that would not be happening at the households in the deprioritized area. And then explaining that there's a separate marking code for the households to indicate that they were part of the deprioritized area. We also included some key messages and what we anticipated might be some potential concerns around the ITN deprioritization. So a few key messages that we wanted to make sure were still passed to the households in these deprioritized areas was to emphasize the importance of other measures such as IPTP, so for pregnant women, preventative treatment for pregnant women, and also prompt treatment seeking for fevers. Some net care messages, so the households that had nets anyways, to make sure to communicate that those nets should be taken care of and how they should be taken care of. And also just a reminder that pregnant women and fully vaccinated children under 5 were still eligible to receive ITNs at their nearest health facility through routine distribution channels. And then some potential concerns that we anticipated were first that maybe campaign teams wouldn't adhere to the protocols and give ITNs anyways. Households might refuse the SPAC, so the SMC, because they weren't also receiving ITNs at the same time, or that households would be skipped for that SMC because they weren't going to be receiving ITNs. Now I'll go into some observations of the activities during leading up to and during the campaign. So I've sort of boiled down all of the observations. First starting with what we actually did. So we had a team of 3 observers who attended all of the training activities and then also went with the distribution teams in the field. They had sort of 2 forms. One was a paper form that was a daily observation form where they filled out things around what they saw being communicated about deprioritization in the training, what information was received by the teams, and if there were any challenges or frustrations that were being expressed in those activities, in those trainings, and who was expressing that frustration or that confusion. And then what successes were also observed. And then they had the household observation form, which they had on a tablet with them when they went out with the distribution team. And they were recording some characteristics of the household and whether that household had children who are eligible for the SMC, if those households received ITNs or the SPAC for SMC, what messaging was received by the household, and if there were any reactions to the deprioritization from the households. Yep, so just boiling down some of the observations that the team made during that preparation and training phase is that generally people took the information quite well. There was a good understanding in the supervisors around the reason for deprioritization and what it actually entailed. As I think we probably expected, there were some concerns around the community being unhappy with that deprioritization. Particularly, they flagged vulnerable groups, so pregnant women or people of lower socioeconomic status that were still in those deprioritized areas. And then there was also some concern about the team not being clear on where the line was for the deprioritized settlements and for neighboring settlements that were not deprioritized. They also discussed mitigation strategies for all of these concerns. So again, clarifying that ITNs would be available through routine distribution, working with the ward supervisors to make sure that the information was passed in such a way and to the relevant people to limit the spread of rumors. Likewise, working with the town announcers to really emphasize the SMC messaging in the deprioritized settlements, and making sure that that they were really only passing the SMC announcements in those settlements. Emphasizing this interpersonal communication to manage any agitation from the community. And then the LGA team also made themselves available by phone if the distribution team felt that they needed to refer somebody who was quite angry. So. Getting into now the observations that they made during the distributions. So our team observed the distribution team approaching 441 households in all 13 of the settlements that were selected for ITN deprioritization. They were able to observe the exterior of all of these houses. So sort of the material of the wall, the material of the roof, whether there was an AC, whether there was a car. Then they entered 88 households with the team, so about 20% of the total households that they entered. And most of the reasons why if they didn't enter a household, why they didn't enter was either there was nobody home, so the household was empty, the household didn't have any SMC eligible children, so the team just continued on, or the household refused the team from entering into the household. First, just talking about what the houses looked like. So nearly all of the households were made with what would be considered modern building materials. So cement blocks, had windows, most had window screens and a wall around them. So kind of what you see in these photos here is pretty typical and also consistent with the targeting of formal settlements. So that the household construction was observed was very much in line with the way that the settlements were selected. In 6 of the 13 settlements, most of the households again had air conditioning units. So again, a sign of the relative level of the households. And then in a lot of the settlements, a lot of the houses had cars. So again, just sort of in line with what we'd expect given the selection criteria that was used. Then there's this question around whether the SMC eligible children in these households in the deprioritized area were receiving SPAC. And well, actually the first point is whether they received an ITN. So none of them received an ITN, which is in line of what should have happened. Most of the SMC eligible children in these households did receive SPAC. So 82% of the children that were in households that were observed. And in many cases, this was administered as directly observed therapy, or if the children weren't home, then the household was marked for a revisit. In a few instances, they left the SPAC with the caretaker to administer later, but mostly it was done through direct observed therapy. In terms of SBC messaging, so all of the households that were observed received the messaging around SMC. And then about half of them actually received an explanation of ITN deprioritization. So on the right here is just the different messaging and how much they, what percentage of households they observed actually receiving that messaging. And I just really like this photo showing interpersonal communication in action. The distribution team in the yellow vest talking to the household, and again showing the construction of these houses in these deprioritized settlements. Oops. Okay, so I'm just going to walk through this flow diagram. So as I said, they went to 441 households. They entered 88 of those households. So that's the left side of this flow diagram. When they were in the household, the observers also had the opportunity to record any observations that they had about the household reaction to the team or to the deprioritization. So in most cases, they actually recorded nothing, or they recorded that it was very routine, that the household was not upset and was happy to comply with the SMC. In a few instances, the households did request an ITN, not referencing the deprioritization, just saying that we'd quite like an ITN. There were a couple households that were unhappy with deprioritization. And I've just put a quote from the observation team here that they recorded of one of those households. And there was a little hesitancy towards SMC. But for the most part, most of these visits in these 88 households were routine. And then they also had the opportunity to make any notes on any of the households. So there were a few, so 13 households where they didn't actually enter the household, but they still made some comment about, oh, the eligible children weren't home, or the household didn't want SPAC, or they were asking for an ITN. So these are the sort of some additional comments that the observation team made about some of the households. Oops. There we go. So just to summarize that, the vast majority of the interactions that the team observed were routine. There was a few expressions of dissatisfaction with the deprioritization and requests of ITNs, but for the most part, it's a small number of households. Okay, so that kind of encompasses all of the observation that was done during the distribution campaign. Now I'm going to move on to the household survey. So this was done in December, a little while after the end of the distribution campaign. And the way that this was done was we had a team of 5 data collectors and 1 supervisor. We had 20 clusters in settlements that were deprioritized and 20 clusters in nearby settlements that were quite similar, 15 households per cluster that we randomly selected. And then the team went and interviewed an adult member of that household. And we were looking primarily at the percentage of SMC eligible children that received SPAC and the percentage of population with access to an ITN within their household. So just some summary statistics of the visits. So they were able to visit the target number of households. So we had aimed for 300 households in each group, the deprioritized and non-deprioritized. We met that. The household size was about what we were expecting. But what we found was that actually a lot of these households did not have SMC eligible children. So there's much fewer SMC eligible children there than we had anticipated in our power calculations. In terms of the SMC eligible children that were there, most of them did receive SPAC. So it was a successful visit in that way. But there was fewer households that reported actually remembering that visit from the distribution team in the deprioritized area compared to the non-deprioritized area. In terms of nets, so we audited between 272 in the deprioritized area to 492 in the non-deprioritized area. Obviously, as you might expect, the mean number of nets was lower in the deprioritized area, but there was still this 33% of households that reported having received an ITN during a visit from the distribution team in that October visit. And generally, given that there are fewer nets in those households, there is also lower access to ITN in those households. In the deprioritized area compared to the non-deprioritized area. So just to sum up what we found, both with the observations and with the household survey, and I've done this sort of by concern. So I sort of presented some of the concerns at the beginning of what we anticipated. And the first one was our team's going to actually adhere to the deprioritization protocol. And with the observations, we would say yes. So there's no observations where the team gave an ITN when they weren't supposed to. But there is still this 33% of households in the deprioritized area that reported having received an ITN. And I'm happy to talk a bit more about what I think is happening there. We were concerned that households might not be willing to participate in the SMC component in the deprioritized area if they weren't receiving an ITN. but we didn't really see any strong evidence of that. And in our household survey, most SMC eligible children had received SPAC. We were worried there might be frustration or anger from households in the deprioritized area that they weren't receiving an ITN. And again, with what we observed, we didn't see that. But again, this is a subset of that population. And then the last one is there's concern around the teams being able to see where they were moving from the deprioritized area to the non-deprioritized area. And that did turn out to be an issue. So in the future, if this is being done elsewhere, a recommendation is to make sure that there are very clear, high quality maps that the team can use in the field to make sure that they're going and applying the right protocol in the right place. My last slide is just to say, so we've done the observations, we've done the household survey, and what we'd like to do in the next year is to do some passive case detection in the deprioritized areas and also the non-deprioritized areas to see whether there's any observable differences in incidence of malaria in these areas. So I'll just say thank you very much for your attention. And that's all.
So thank you very much. We'll take some questions for the two presentations. Yes, at the back.
Thank you very much to both presenters. My question is on what was the share of households that was deprioritized across all households that were considered? What was the share that was deprioritized? And the reason I'm asking is, does the saving in the nets justify the increase in operational complexity of delivery? Like as a cost effectiveness, if you're trying to deliver less nets by targeting, but adding a lot of operational complexity, does it work out? Over.
Okay, Eric.
Merci beaucoup. C'était une présentation, une très bonne présentation. J'ai juste une question de compréhension. Vous avez commencé à déprioriser après les Subnational Tailoring Intervention Exercise, ou bien c'est un problème d'argent et puis vous vous êtes référé au Subnational Tailoring Interventions. Am I clear?
Thank you. So
Thank you for the.
Please just repeat again the question.
OK. Bien. Je disais ceci. L'exercice a commencé, ce ils viennent de faire. Est-ce que c'était guidé par les Subnational Tailoring Interventions et qui se sont dit qu'on abandonne certaines interventions là où on ne peut pas le faire, ou bien c'était guidé par l'enveloppe financière? Merci.
Thank you for the presentation. My name is Shonde Akinola. I work with CRS. Just looking at it looks like a lot of things happened in Kwara State at the same time. We had integration, we had deprioritization. We also had, I think we also introduced ICT4D at the same time. I think it will also be nice for us to hear how were you able to manage the coordination with key stakeholders, considering the fact that a lot of things are happening at the same time, programmatically. Thank you.
I didn't see where the question was coming from. So please raise your hand so that it's clear. Okay, we'll take one more from Estefanos.
Thank you very much.
My name is Stefanos from the Global Fund. This is a wonderful exercise, really. I just wanted to know for those households that were deprioritized and during survey, they had actually some ITNs in the households. And from your presentation, it's very clear that I think these households were economically well off in terms of both the construction materials, many of them owning cars. So have you had an opportunity to check whether there were actually alternative providers of ITNs for these households, like commercial ITNs, because it seems that they probably could afford to buy those. Was there also any question as part of your evaluation, probably to assess their level of willingness to pay and then get, if no alternative ways of availing ITNs would be possible? I know that this is a deprioritization exercise, which means these people doesn't mean that they don't need ITNs, absolutely, but it means that then we have to actually prioritize the most important, the most affected groups. So I was actually just wondering, whether you had an opportunity to look at that dimension as well. Thank you.
Sorry.
Unfortunately, the speaker did not get it clearly. Would you repeat again?
Can you hear me now very well? Okay, thank you. No, thank you very much. No, my question was really with regard to availability of ITNs in the households that were deprioritized. And you also mentioned, I think from your assessment, it was very clear that these households were economically strong. They owned cars. It seems that these are households that can afford to buy ITNs if they become available through other routes like commercial routes. So my question was, is it possible that some of the nets that your teams observed in those households were because they actually managed to buy from somewhere else, not necessarily through the distribution of the ministry? Then the second point was that, I was just wondering, as part of the survey, as part of the evaluation, whether there was an attempt actually just to check the willingness of those households actually to acquire nets if it becomes available through commercial route, not necessarily through free distribution.
Okay, great. So I'll start, I'll go in order that the questions were asked. And please, if I am not answering your question, please repeat it. So the first question was about sort of how many nets are actually being saved by this approach. So I think that's an excellent question. We don't have the difference in number of nets, but we can look at the difference in with the population that was in the deprioritized area. I think it is very important to note that because this is a combined campaign, the savings is in the nets and not in the time, because they are still having to go door to door to do the SMC, whether or not they're giving an ITN. So I think there is potential for more savings on the ITNs if the deprioritization was expanded, but I will say this is a fairly small area for this pilot study. So I think there's more to do to look at that. Then there was a question around whether the motivation here was subnational tailoring or whether it was savings or price for the ITNs. So the impetus for this was around reducing the spend on nets, given that in the next grant cycle, we anticipate that there won't be all of the nets needed to cover everyone at universal coverage. So in anticipation of that, understanding if there are areas where we can deprioritize ITNs in order to save on those nets. But I think that's not to say that there couldn't be a benefit in both sense. It may also be an opportunity to refine on subnational tailoring. Then there's a point about how there's a lot going on in Kwara State. I think that's a very astute observation, and I think it would be great to get some input from the team from Kwara who is here, if they have anything to add to that. I think absolutely communicating with key stakeholders was important, and I think that that was done quite well, but there's room for improvement, and there is ongoing discussion and sort of learnings from these activities, how to better coordinate the ITN campaign and the SMC campaign to do it more efficiently in the future elsewhere. So I think just flagging that there's always room for improvement. And this is a really valuable experience for learning for these sorts of integrated campaigns, which I think we'll talk about a bit more tomorrow. And then there's the question around the ITNs in the households that were deprioritized, which is my favorite question. The 33% represents households that said they were visited by the team and they received an ITN from that team. So it is specifically asking about nets received as part of the campaign. It is true that the households in the deprioritized area had nets from other places. Some of that were nets that they'd purchased. But in this case, the 33% represents households saying that they got a campaign net specifically. So I think there's a bit more that we can do to look at that. I think there's a couple possibilities. One is potential confusion around if they got a net through routine distribution, are they considering that as a campaign net? Another possibility is confusion around those borders of where it goes from deprioritized to not deprioritized. Maybe there were some households that there was confusion on where they actually fell in the area, in which area. Or maybe while we didn't observe the teams giving ITNs where they weren't supposed to, when we weren't looking, it is possible that they were still giving ITNs to some households. So, great. Thank you very much.
Okay, one more question. If there's one more question, yes.
All right, thank you very much to the two presenters. I don't know if the first presenter is online, because my question is to her. My name is Zainab Ali from Nigeria. When they were collating data to review during the analysis, I know in the urban setting, we have a lot of people that access private facilities. So in the course of collating data, were they able to get data from private facilities, or was it just the public facilities that they focused on during the exercise? Then the second question is for Eleanor. I noticed in the data you've mentioned quite almost 2/3 of the houses that were meant to be visited by the interviewers, they couldn't gain access. Do you have any reason why that happened? Because it's a large chunk. Is it because they were unhappy because they were deprioritized, or there was a reason specifically why they refused the interview? Thank you.
Okay, we'll start. Unfortunately, we can't take more. So Ifoma, go ahead.
Yeah, so with respect to the data for the test positivity in referenced here, we mostly collected data or had data from public health facilities. Routine surveillance typically has mostly public health facilities to them and a few private facilities, but the majority of the data that we had was from public facilities. Does that answer the question?
I think so, yeah.
Great. Thanks, Zainab. That's a really good question. I think you've picked up on something important, which is that actually a lot of these households were either empty or didn't have SMC eligible children, which is, so in most cases, that's why the team didn't enter. There were some cases where the household just didn't want the team to enter, but mostly it was because the house was empty or they didn't have SMC eligible children. And that is possibly a result of the selection criteria for the deprioritized area, is that you're selecting an area where there isn't a lot of people living full time, or they're at work, or they don't have, or they don't have children in the SMC eligible age range. So, yeah.
Okay, so can we thank the two presenters? That's all. Thank you very much. So our last one is experiences and challenges in Guinea.
Bonsoir à tous. Je suis Abdourahmane Diallo du Programme national de lutte contre le paludisme donc de la République de Guinée. Donc, c'est avec plaisir que je prends la parole cet après-midi pour vous partager les résultats préliminaires donc, de nos travaux portant sur la microstratification urbaine, donc à Conakry, capitale de la République de Guinée. Donc, nous allons aborder quelques progrès que nous avons accomplis dans l'exercice de ce travail, les défis auxquels nous avons été confrontés et peut-être envisager des recommandations et des prochaines étapes pour réaliser ce genre de travail. Slide. Alors, quel est le contexte du paludisme en Guinée pour rappel? Des progrès ont été réalisés dans la lutte contre le paludisme en Guinée au fil des années, donc à l'image donc, de la plupart des pays donc, endémiques du paludisme ces dernières années. Donc, nous avons connu une baisse considérable de la prévalence du paludisme donc, en 2012 et 2022, donc, allant de 44% à 17%. Donc, avec l'accompagnement des partenaires, la disponibilité donc, des outils de prise en charge, les capacités donc, diagnostiques et de prise en charge ont nettement été améliorées, donc avec une forte réduction donc, des cas de décès hospitaliers dus au paludisme. Donc, également, le renforcement de paquets d'activités qui existent dans la lutte contre le paludisme en termes de prévention, de prise en charge, mais également concernant la surveillance du paludisme. Donc, ceci est illustré sur cette courbe que vous avez. Et vous avez une décroissance considérable donc, des cas de décès et une augmentation des cas positifs rapportés, donc qui peut être liée à l'amélioration des capacités de diagnostic du système de surveillance que nous avons au niveau du pays. Malgré cela, le paludisme reste quand même un problème de santé publique en Guinée. Donc, c'est la première cause de consultation et d'hospitalisation. En 2023, nous avons rapporté près de 5 millions de cas de paludisme suspects, donc dans les formations sanitaires et au niveau communautaire à travers les stratégies de santé communautaire. Et nous avons confirmé près de 2 500 000 cas de paludisme. Donc, le profil actuel épidémiologique du paludisme se présente comme suit. Vous avez donc la moitié du pays donc, qui se trouve dans la catégorie des zones de haute transmission et de très haute transmission. Donc, les districts que vous avez donc, à l'est et au sud. Donc, vous avez 18 districts sanitaires donc, qui se trouvent dans la catégorie des districts donc, de moyenne et faible transmission. Donc, et vous avez la zone de Conakry, donc où vous avez à peu près 2 millions d'habitants qui se trouvent dans cette zone, où vous avez une prévalence donc, qui est très basse, qui est à 0,4%. Donc, une zone où le niveau d'incidence est également très bas. Okay. Donc, pour rappel, le processus de SNT en Guinée date de 2021 pour la première fois, donc réalisé dans le cadre donc, de l'approche High Burden, High Impact, donc de l'appui réservé au pays dans le cadre de la stratification. Donc, cette première stratification a été réalisée donc, à mi-parcours de notre plan stratégique en 2018-2022. Donc, vous comprendrez qu'il n'y avait pas assez de possibilités pour ajuster sur les planifications stratégiques qui ont été envisagées, mais il a été réalisé également dans le contexte du NFM3 après la soumission et même le démarrage du projet. Donc, en 2023, nous avons refait cet exercice sur la demande du pays. Donc, le cadre a un peu changé. Donc, nous avons mis en place donc, une équipe pays qui a travaillé avec toutes les parties prenantes au niveau local pour développer nos approches et travailler avec l'Organisation mondiale de la santé donc, pour établir ce cadre de stratification du risque du paludisme. Donc, partant des objectifs que nous avons pour notre plan stratégique et notre demande de financement adressée au Fonds mondial dans le cadre donc, du GC7. Donc, ceci a été réalisé donc, dans un processus complet qui a touché l'ensemble donc, de nos besoins en termes d'information et de sous-stratification. Alors, cet exercice a été réalisé dans le contexte que vous savez, je ne vais pas revenir là-dessus, beaucoup l'ont abordé. Okay. Donc, je ne reviens pas là-dessus, beaucoup l'ont abordé. Nous sommes dans un contexte donc, de récession au niveau mondial, les ressources se raréfient, donc il faut aller vers la priorisation. Donc, les ressources dont on a pu mobiliser dans l'exercice de mobilisation des ressources en 2023 ne nous ont pas permis d'envisager la campagne donc, de distribution de moustiquaires de masse en 2025 à Conakry. Donc, nous nous sommes posé la question, alors, si on ne fait pas la distribution de la campagne à Conakry, qu'est-ce qu'il faut faire? Donc, Conakry, on va le voir plus tard, donc, a des caractéristiques de transmission du paludisme plus ou moins hétérogènes, donc typique donc, du paludisme urbain qu'on a vu dans les présentations précédentes. Alors, l'idée pour nous, nous avons envisagé un certain nombre d'hypothèses que vous avez ici. Donc, la prévalence du paludisme est très faible à Conakry, de 0,4%. Donc, l'incidence également est faible, elle est d'environ 40% pour 40 pour 1000 habitants. Donc, nous avons estimé que la transmission, elle est hétérogène au niveau de Conakry, qu'il y aurait possiblement donc, des hotspots localisés qu'il faudrait peut-être cibler. Et comme je l'ai dit tantôt, dans le contexte où on n'avait pas de ressources, il fallait envisager quelque chose qu'on allait faire en remplacement de Conakry. Donc, l'idée pour nous, c'était de faire un travail à l'état plus granulaire, donc allant au plus bas niveau donc, du découpage administratif pour voir quels sont les points où on a la transmission du paludisme et envisager des distributions de moustiquaires donc, par d'autres canaux, notamment la distribution scolaire, la distribution communautaire, mais également mettre cette activité dans un cadre plus global pour envisager la lutte contre le paludisme en milieu urbain. Donc, voilà quelques spécificités de Conakry. Là, vous avez la carte de Conakry. Donc, la première carte présente l'incidence annuelle du paludisme pour 1000 habitants. Donc, vous voyez qu'elle est autour de 8,5 et 6,7 par endroit. Et vous avez la localité donc, du centre-ville, du centre urbain de Conakry, donc qui est en noir ici, où vous avez environ 160 cas pour 1000 habitants, à peu près le même niveau d'incidence que les autres localités de niveau de haute transmission. Donc, cette localité est caractérisée par le fait que vous avez le centre urbain, donc les plus grandes formations sanitaires du pays se retrouvent là. Donc, les activités économiques donc, se font dans cette localité. Donc, il y a beaucoup de mouvements entre cette localité et les zones périurbaines qui se trouvent autour de Conakry. Et vous avez Dubrika à côté, donc il y a 296 cas pour 1000 habitants. Également, en termes de prévalence, donc vous avez la même présentation. Donc, comme vous devez le savoir, le revers de la médaille dans la réduction de la transmission du paludisme au niveau urbain, c'est l'exposition des communautés donc, au risque de faire le paludisme grave et avec un risque de décès élevé. Donc, il faut envisager des interventions ciblées bien dans ces localités pour pouvoir assurer une protection optimale des populations. Donc, sur cette carte, vous avez les localisations des grandes formations sanitaires de Conakry. Et vous avez sur ce diagramme des données très intéressantes. Donc, pour rappel à Conakry, plus de 70% de l'offre de soins est donnée par le secteur privé. Et vous avez à peu près 15% du secteur privé qui intègre le système de surveillance et plus de 67% des cas rapportés dans le système de surveillance sont collectés dans à peu près 15 structures sanitaires que vous avez ici. Donc, c'est des grandes structures sanitaires et qui se trouvent toutes pratiquement localisées auprès donc, du centre urbain. Donc, ce qui fait que si vous considérez les données de surveillance et vous regardez les incidences, donc vous pouvez, si vous n'analysez pas ces données à l'étape sous-district, vous ne pouvez pas comprendre à quel niveau vous avez les niveaux de transmission les plus élevés. Donc voilà, je reviens, voilà quelques caractéristiques donc, de ces localités, notamment Kaloum. Donc, c'est des zones à très faible statut socio-économique avec des matériaux de construction de mauvaise qualité. Donc, et la constitution donc, des marécages et des points d'eau autour des habitations. Donc, comme vous devez le savoir, qui constituent des véritables risques de l'entretien de la transmission du paludisme. Donc, ce qu'on a essayé de faire, c'est de faire un effort supplémentaire à partir des données disponibles pour tenter cet exercice. Donc là, vous avez des données, donc la proportion des cas de paludisme confirmés au niveau des formations sanitaires. Et vous voyez que la localité de Kaloum, donc est la localité la plus concernée, qui présente à peu près environ 60% des cas de paludisme. Vous avez également à gauche la distribution donc, des résultats de TDR et de localisation des cas positifs sur une enquête que nous avons réalisée en 2018. Donc, vous avez quelques points. Donc, on a pu observer des cas de paludisme, mais globalement, les cas de paludisme n'étaient pas rencontrés parce que l'enquête de prévalence avait révélé que seulement 0,4% de la population avait le palu. Et la dernière enquête EDS qu'on a réalisée à l'échelle régionale, nous avons pu rapporter que 5 cas de paludisme confirmés. Voilà, donc sur le premier diagramme, vous avez le taux de déplacement en dehors de Conakry pendant les 4 semaines, parmi les patients qui avaient un TDR positif dans cette enquête. Et il se trouve que dans Conakry, au niveau global, 25% des cas de paludisme qui ont été rencontrés dans le cadre de cette enquête ont connu donc des voyages en dehors de la ville dans les 4 semaines qui ont précédé l'enquête. Et c'est notamment dans les zones périurbaines autour de Dubreka et Koya, qui sont des localités à caractéristiques rurales. Donc, sur l'autre graphique, vous avez le gradient du paludisme et le nombre d'anophèles capturés. Donc, les anophèles dans cette enquête, qui était une enquête combinée investigation entomo-épidémiologique, avaient montré que les anophèles ont été le plus capturés au niveau de Kaloum. Donc, on a présenté sur les images tout à l'heure, et quelques communes qui est autour de Kaloum, notamment la commune de Dixine, et pratiquement pas d'anophèles capturés dans les communes de Ratoma et de Matoto. Alors, nous avons conclu cet exercice en se posant des questions. Donc, l'état des données disponibles ne nous permettait pas d'aller au niveau du détail qu'on avait besoin pour pouvoir répondre à toutes nos questions. Donc, selon les facteurs examinés, est-ce qu'on peut exclure la commune de Matam et de Ratoma, donc dans les zones à considérer si toutefois on avait des ressources supplémentaires pour faire une distribution scolaire ou communautaire de moustiquaires? Donc, si on admet cette hypothèse, est-ce qu'il faut envisager que Kaloum et Matoto sont les zones à prioriser dans le cadre de ces exercices? Donc, nous avons suggéré qu'on fasse des investigations supplémentaires dans quelques centres de santé, notamment de Matoto et Kaloum, pour explorer donc les données sur la démographie et le comportement des populations, le contact entre les localités urbaines et rurales. Donc, ces données que nous avions datent de 2017, il s'agissait d'anciennes données, donc il y a la nécessité d'aller vers la collecte de nouvelles informations pour aller faire cet exercice, un exercice complet. Alors, nous avons essayé de lister ici quelques défis auxquels nous avons été confrontés dans le cadre de cet exercice. Donc, les données précises sur le dénominateur de population, donc au niveau sous-district, donc on ne peut pas les avoir. Donc, le découpage administratif est fait de telle sorte et le recensement permettait d'estimer les populations à l'échelle communale. Et à l'échelle communale, on voit qu'on a des faibles incidences. Donc, l'idée pour nous, c'était de disposer de données à l'échelle quartier ou sous-quartier pour pouvoir estimer les populations qui allaient constituer les dénominateurs de l'estimation des indicateurs. Donc, les limites géographiques floues des aires de santé en milieu urbain ne permettaient pas également donc, de suivre la répartition donc, de la carte sanitaire afin de pouvoir extrapoler les indicateurs qu'on calcule sur le nombre de populations couvertes par zone. Donc, la faible déclaration des cas du secteur privé donc, dans le système de surveillance, je l'ai rappelé tantôt, environ 70% de l'offre de soins est faite dans le secteur privé et seulement 15% de ces formations sanitaires intègrent le système de surveillance national. Donc, absence de données et d'évidence sur la mobilité des populations. Donc, est-ce qu'il s'agit des contaminations en zone urbaine ou est-ce qu'il s'agit des contaminations en zone rurale qui sont détectées en zone urbaine parce que les gens viennent pour les activités économiques? Il se trouve que l'accès aux soins est plus marqué dans la capitale au niveau des zones urbaines que dans les zones rurales. Donc, également, absence de données entomologiques récentes en milieu urbain. Donc, les données qu'on avait, c'était des données collectées dans quelques localités et c'est des données qui dataient de 2017. Donc, nous n'avions pas de données récentes entomologiques au milieu urbain parce que toute la surveillance entomologique et les efforts de suivi sont concentrés dans les zones rurales où le niveau de transmission du paludisme est le plus élevé. Donc, nous avions également pas de données sur la prévalence à l'échelle infrarégionale. Donc, absence de données sur les caractéristiques donc, des habitats et absence de données et de coordination donc, entre les départements de la santé et les acteurs impliqués dans la planification et la gestion des communes. Également, nous nous sommes inscrits dans l'objectif d'envisager quelle va être la perception de la communauté d'un tel exercice. Donc, nous venons de le voir dans la présentation de notre collègue du Nigeria, qui a interpellé sur la possibilité d'impliquer les communautés dans le cadre de cet exercice. Parce que si vous décidez de retirer les moustiquaires donc pour couvrir 2 millions de personnes, il faut pouvoir l'expliquer à toute la communauté pour qu'elle puisse adhérer à votre projet. Mais également, nous n'avons pas eu de ressources pour continuer ce travail. Donc, l'absence de financement a été également un défi pour aller collecter les données nécessaires pour pouvoir compléter cet exercice. Les prochaines étapes. Donc, nous avons engagé un plaidoyer auprès de quelques bailleurs pour mobiliser des ressources afin de faire une microstratification urbaine pour informer la prise de décision de la lutte contre le palu au niveau de Conakry, donc faire un exercice plus complet. Donc, ce travail a pour objectif, premièrement, de déterminer donc la prévalence, l'incidence du paludisme et la couverture des interventions donc à l'échelle admin 4, vraiment aller dans la sous-stratification, par les districts à l'échelle admin 4 pour pouvoir localiser les hotspots et les points où le niveau de transmission est le plus élevé. Deuxièmement, déterminer donc le type de vecteur, et la densité et leur comportement à travers des enquêtes entomologiques mensuelles, donc collecter des données entomologiques. Troisièmement, déterminer donc la dynamique de la transmission du paludisme, les caractéristiques socio-économiques et la mobilité des individus en milieu urbain. Définir donc les limites des aires de santé à l'aide des données du dénombrement. Donc, nous disposons actuellement de données donc, qui peuvent aider à faciliter donc, ce découpage et l'estimation des populations avec les données actualisées à l'aide de données géographiques pour pouvoir, à la fin de cet exercice, pouvoir dire dans l'ère donc, de couverture de santé, voilà quel est le niveau donc, de transmission et voilà dans quelle localité il faut agir pour contribuer à réduire donc, le fardeau du paludisme et développer donc, des outils d'analyse complets pour appuyer cet exercice. Alors, quelques aspects à considérer pour les pays où la réalisation d'un travail pareil. Donc, c'est de faire une revue complète des données disponibles donc, avant d'entreprendre ce genre d'exercice. Donc, intégrer ce processus donc, dans un paradigme plus large de lutte contre le paludisme, donc pour envisager des orientations dans le cadre de la prévention, la gestion des cas, mais voir cet exercice comme un élément qui peut aider à l'utilisation rationnelle des ressources. Donc, aujourd'hui, on parle de raréfaction des ressources, donc il faut aller vers cet exercice, notamment dans les villes où nous avons des millions de personnes. Les ressources dont nous disposons ne nous permettront pas de couvrir toutes ces personnes. Donc, ce genre d'exercice peut aider en amont de la planification stratégique à rationaliser les ressources. Donc, engager toutes les parties prenantes nationales dans le cadre de ce travail, comme je l'ai dit tantôt, les communautés, donc les autorités locales, donc les autorités communales, parce qu'il faut après développer une stratégie plus complète pour aider à gérer cette problématique du paludisme urbain. Donc, mobiliser également des ressources pour réaliser une microstratification complète, parce qu'à l'état actuel de nos systèmes de surveillance pour la plupart des pays, donc vous n'auriez pas toutes les données nécessaires pour faire un exercice complexe, ça, si vous vous engagez dans le cadre de ce travail. Alors, on m'a posé une question que j'ai voulu aborder ici. Donc, quel est mon avis sur le compromis qu'il faut faire entre utiliser les ressources qu'on pourrait mobiliser pour acheter des moustiquaires, ou acheter des intrants, ou financer la surveillance. Donc, je n'ai pas la réponse magique à cette question. J'espère que les débats permettront peut-être d'orienter un peu sur l'approche qu'on devrait avoir dans le cadre de cet exercice. Donc, je voudrais terminer par remercier Alioune Camara, donc coordinateur national du PNLP, Jaline et Ousmane de Nord-Western et Béa, également le Fonds mondial et l'USAID pour leur appui à la lutte contre le palu, et l'ensemble des partenaires qui ont également appuyé la Guinée jusqu'à présent dans la mobilisation des ressources pour le financement des campagnes, notamment AMF et d'autres partenaires locaux que nous avons en Guinée. Merci.
I'll say well done. Yes, I think he said we should have a discussion. So this is your time to ask a few questions. Yes, go ahead, please.
Thank you. This is actually a question for any of the programs who've been doing the urban microstratification. I'm interested to know what a successful outcome would look like for you, or what the plan is to evaluate the microstratification in terms of, I guess, in terms of how malaria evolves in those areas where you've done the stratification. And would you ever envisage a situation where whatever the outcome is in terms of malaria, you decide that you would never go back to complete coverage, even if you had the money? So is there a possibility basically that you will show that this is actually a sensible way of doing it, regardless of funding availability?
OK. Merci. Moi, je vais m'exprimer en français. C'est le secrétaire permanent pour l'élimination du paludisme, délégation du Burkina Faso. Je suis donc avec une délégation. Et moi, je voudrais juste faire un commentaire qui pourrait peut-être avoir pour nature une question à la fin. Mais avant tout, c'est d'abord remercier l'AMP pour avoir invité le Burkina et également remercier tous les partenaires qui nous assistent dans cette lutte et enfin remercier tous les présentateurs, dont le dernier qui a fait une brillante présentation. Alors, mon commentaire qui a peut-être forme de question, c'est que depuis ce matin, on se rend compte que toutes les présentations laissent croire que la prévalence et la transmission dans les zones urbaines est faible par rapport à ce qu'on constate au niveau des zones rurales. Alors, c'est peut-être une inquiétude pour le Burkina, parce que malheureusement, nous n'avons pas eu l'occasion de pouvoir faire une présentation. Sinon, on aurait dû aussi présenter quelque chose. Mais ce que nous constatons, c'est que chez nous, les districts urbains ont beaucoup plus de cas. Donc, ça contraste avec ce que nous on a eu depuis le matin. Et là, le commentaire qui vient sous forme de question, est-ce que cette tendance à faible transmission, elle est liée au statut économique des ménages en ville ou bien elle est simplement liée aux zones géographiques qui sont donc les villes? Parce que là, ça contraste avec la situation du Burkina. À ce titre, est-ce que réellement déprioriser les grandes villes où les ménages économiquement peut-être acceptables n'entraînerait pas peut-être un risque de flambée et même de revirement de situation? Parce que là, c'est vraiment une situation difficile à comprendre pour le cas du Burkina Faso. Et enfin, maintenant, faire un plaidoyer pour les partenaires. Le Burkina aurait aussi voulu stratifier, micro-stratifier, faire une étude approfondie au niveau de nos villes pour comprendre est-ce que c'est le cas du Burkina qui est spécifique ou bien il y a matière à réfléchir. Donc, c'est en même temps un plaidoyer pour aider le programme PALU du Burkina à pouvoir donc réaliser une telle investigation au niveau de ces grandes villes et peut-être même ajouter d'autres aspects pour mieux comprendre. Je vous remercie.
Okay, thank you, Dr. Jallo. I'm going to be a little bit more provocative with you. In your last campaign, we didn't have enough nets for Conakry, but it was a very, very political decision, right? To move ahead and mobilize the nets. So my questions are two, what has been the engagement at the highest levels of the government to get that buy-in? Because your political base, your voting base is sitting in Conakry. And obviously there's been some issues around instability. And then the second piece is really, if you don't mobilize the resources to really know where transmission is taking place, like you know where they're diagnosing it, but where the transmission is taking place, how will that affect the political engagement around the decisions that you're taking? Just recognizing that over years you've had this discussion, but it's often been stopped for not an epidemiological reason, but more of a political reason. Thanks, over.
One more.
Thank you very much, moderator. Mine actually is not a question, but could it lead to a question later to the Ghana presenter this morning? I actually appreciate and congratulate the presenters today. My name is Sylvester Kazi. I represent A to Z Textiles. We are manufacturers of LLIS. With my experience and with what we have been seeing since morning, and with specifically the issue of urban malaria versus rural, with my experience and from the meetings I've been participating so far, there has been a query from the urban people that the nets which are distributed during mass campaign and all, that's small. But from experience, you could understand that the urban houses and the beds are quite big compared to the one-size-fit net, which are normally in the campaign or distributed during the campaign. Now, in that case, you will find that the urban people, normally, even if they are given those campaign nets, most of them will take them to the village later on, maybe when they go for a visit, and give us a gift. But for them, they use untreated nets, the big one, the Chinese nets, so to say, which are very common, and some of which are even operated by a remote control. And for that case, you will find that in most of the urban people, even most of us sitting here, I think we are using nets which are not the program or the campaign nets because of the size of the bed nets and the infrastructure in the house. Because in urban, a net is a furniture. So it has to comply with what is actually is tutored in the bedroom. So in this case, I think what Ghana has told us this morning, that they have gone further and they have what they call tailor-made, which means they consider requirements for different individuals. So in that case, I don't know if Ghana had a different source of funding which allows them to procure nets of different sizes to match the urban requirements. Because from what I understand, for donor-funded programs, you have to go to what they call one size fit for a country. For example, in Tanzania, we have a specific size for the campaign nets. But if it's school or if it's mass campaign or something like that, and actually we understand it makes life easy, it makes the distribution easy, and you can cover a bigger population with in that case. Now, maybe Ghana could tell us more how they have actually managed to break through and having this possibility of distributing nets of different requirements and needs to the urban people. Thank you.
Okay, merci. Could you repeat your question in French? The two questions, yes, on transmission and political, yes.
Sorry, I even threw them out. So the first part of the question was really, Conakry has been very political in terms of nets. So even for the last campaign, we didn't have resources, and it was a major mobilization because politically it was important to cover Conakry. So my first question was, what have you done to engage high-level government to get buy-in on the process? Because it's nice on paper, but if nobody's going to listen to it later, It's not going to help us. And my second question was, you're looking at FOSA, which have diagnosed cases, but you have a lot of movement in and out around Conakry, not just after a case, but people coming in for work, maybe getting diagnosed here, but they live 15 kilometers away. So without the data from the second piece to trace the transmission to where it's happening, how do you then ensure that political buy-in and that people believe the stratification you've done, or do you get stuck because you can't do that last step? Over.
So Dr. Diallo will answer the question, then we'll take one or two more. And yes, and if no, also if you can be able to step in on the Ghana question. Okay.
OK, merci à tous pour l'attention que vous avez portée à notre présentation. Je vais essayer de répondre à la mesure du niveau de compréhension que j'ai eu de la traduction. La première question concernait les résultats auxquels nous sommes parvenus. Donc, comme je l'ai présenté tantôt, nous n'avons pas pu conclure dans l'exercice que nous avons fait parce que les données que nous avions ne nous permettaient pas de répondre de façon factuelle quelles sont les localités sur lesquelles on devait prioriser. Donc, il est envisagé à travers d'autres partenaires donc, de rediriger certains sites sentinelles aujourd'hui qu'on a vers Conakry pour réaliser donc, une surveillance entomologique plus rapprochée pour collecter des données et également faire le plaidoyer pour mobiliser d'autres ressources pour compléter cet exercice. Mais je répète encore une fois, les données que nous avions à notre niveau ne nous permettaient pas de conclure sur cet exercice. Donc, nous avons plutôt conclu en se posant des questions. Alors, le commentaire donc, du collègue du Burkina portant sur la faible prévalence du paludisme en zone urbaine. Alors, je pense que c'est une caractéristique, en tout cas, que j'ai observée chez nous en Guinée et les pays autour de la Guinée. Je ne connais pas le cas particulier du Burkina, mais je pense qu'il serait intéressant, comme vous l'avez dit, donc de mobiliser des ressources ou de faire ce genre d'exercice pour comprendre pourquoi le paludisme donc, au niveau donc, des zones urbaines donc, du Burkina n'a pas les mêmes caractéristiques que les restes du pays de l'Afrique, notamment autour donc, du Burkina. Il se trouve que nous n'avions pas également toutes les réponses à cette question. Donc, cet exercice a été fait pour vraiment comprendre est-ce que la situation présentée à travers les enquêtes et les données de surveillance est-elle réelle ou c'est une situation sous-estimée. Donc, je pense que l'exercice de sous-stratification pourrait permettre de répondre à ces questions. Est-ce que c'est le statut des ménages qui fait que les caractéristiques du paludisme peuvent différer d'une ville à une autre? Bien sûr, je pense qu'il y a les caractéristiques des habitations y est pour quelque chose. Il y a le comportement des vecteurs, mais il y a également les caractéristiques socio-démographiques qu'il faut considérer dans le cadre de ces exercices. Donc, nous l'avons vu tout à l'heure pour Conakry, si vous considérez la commune de Kaloum, donc vous avez une incidence de plus de 100 cas pour 1000 habitants. Donc, vous faites une prévalence, vous avez une prévalence qui est autour de 0, et quelques. Oui. Donc, est-ce que c'est parce que les gens séjournent en dehors des villes et se retrouvent dans les centres urbains autour des zones socio-économiques, autour des centres de marché pour fréquenter, faire de l'exercice commercial? Est-ce que c'est parce que les gens font ces mouvements-là et qu'ils se retrouvent dans ces localités et qu'ils consultent plus tard dans les formations sanitaires et qui sont comptabilisés au compte de ces centres qu'on a ces cas d'incidence. Donc, c'est seulement cet exercice de microstratification qui peut permettre de répondre à ce genre de questions. Par rapport à la question portant sur comment on a procédé pour Conakry en 2022, effectivement, donc la campagne de Conakry en 2022 était politiquement soutenue, comme vous l'avez dit. L'État s'était engagé à acheter des mildas pour couvrir une partie donc, de Conakry avec l'appui de l'AMF. Si je ne dis pas de bêtises, je donnerai peut-être la parole à mes collègues qui sont au fond pour donner plus de détails. Donc, des moustiquaires, je crois, disponibles au niveau donc, de Fonds mondial et de PMI avaient été mobilisés pour combler le gap de Conakry. Et l'État a essayé plus tard donc, de rembourser ces moustiquaires en achetant 1 million de moustiquaires qui ont été introduits dans la distribution de routine. Et comment on va faire si on n'a pas de ressources pour faire cet exercice de microstratification et qu'on n'a pas de ressources pour acheter les mildas ouvrir Conakry, c'est le plaidoyer. On va faire le plaidoyer pour mobiliser les moustiquaires. Parce que si on n'a pas les moustiquaires, on n'a pas la microstratification, on va se retrouver dans une situation où on ne pourra pas comprendre donc l'épidémiologie de transmission du paludisme et ça risque de saper un peu les opportunités et les progrès que nous avons eus au niveau de Conakry et globalement au niveau du pays. Donc l'idée pour nous est de travailler avec tous les partenaires que nous avons pour les engager à nous accompagner, à mobiliser des ressources pour comprendre, identifier les localités donc les plus à risque et distribuer les moustiquaires donc qu'on aura à travers des stratégies qu'on a développées et tout de suite dans la présentation à travers le canal scolaire de distribution des moustiquaires qui va cibler les enfants de 0 à 5 ans ou de 5 ans et plus dans les écoles, mais également à travers la distribution communautaire qui se ferait de façon ponctuelle. Donc, c'est des stratégies que nous avons envisagées dans notre plan stratégique et je pense qu'on fera le plaidoyer pour pouvoir les réaliser, pour ne pas laisser environ 2 millions de personnes sans mesure de protection. Alors, dans la présentation du collègue de Tanzanie, je ne sais pas si c'est le traducteur, mais vous avez plutôt parlé de Ghana. Donc, ce n'est pas Ghana, c'est la Guinée. Alors, nous n'avons pas eu ce genre d'exercice en Guinée. La chance qu'on a eue pour toutes les campagnes que nous avons faites, nous avons eu des moustiquaires de même taille. Donc, nous n'avons pas eu de difficulté à distinguer dans quelle localité il faut mettre les petites tailles ou dans quelle localité il faut mettre les grandes tailles. Donc, je pense que c'est cet exercice qui va se faire en 2025. Nous avons pu, en tout cas, obtenir de la part des partenaires qui puissent nous accompagner pour avoir des moustiquaires de grande taille. Vous l'avez dit, dans les zones urbaines, les lits sont de grande taille, mais je vous informe en Guinée qu'on a la culture à utiliser les lits de grande taille. Même dans les villages, vous avez des lits de 4 places, donc qui occupent beaucoup d'espace et qui ne peuvent pas être couverts par les moustiquaires de petite taille. Je vais me limiter là. Merci.
So I don't know whether I give 1 minute to Ghana team to just respond.
Okay, thank you for finding a way of coming back to Ghana. So we, oh, I'm joking and now I forgot what I was going to say. Yes, thank you. So what you described is actually where we want to get to and get people the kind of nets that they want. We are not there yet, but the efforts we've done to get there is with the private sector and not with donors like PMI or GF. So we approached the private sector. We have even approached Vestergaard, and this is based on a project that was done by PSMP some years ago. And we noticed that if you give people the kind of nets they want with zippers, with Velcro tapes, with remote controls, they are most likely to use it, especially in the urban areas. So we are approaching companies like Vestergaard to see if they can produce these for the urban areas. And we are also approaching the other private sectors within Ghana, like EcoBank, to see if they can fund some of these projects. But the only hitch right now is that we would need to give the manufacturers volumes. We haven't been able to get over that hurdle yet, but that's the plan. Thank you.
Thank you very much. I think we can now clap for Yando. Okay. Okay. So thank you for being patient. I'll now hand it over to Jason to wrap up the day. Thank you.
Great. And before Victor leaves the stage, I'd just like to give him a huge round of applause. He moderated the longest session in AMP partner history. And as well to all the presenters today, congratulations on great presentations. So thanks again, Victor. You delivered us right on time. So thank you very much. Just quickly, the cocktail is this evening. It starts at 6 o'clock and it's down near the pool. You'll see they're already setting up. You need to bring this little badge to have entry into the cocktail. So just bring that badge with you. All of the PowerPoints from today are already up on the AMP website. So if you want to direct your colleagues or friends to those, you can point them there. What we did is the feedback from last year was that there was a request for more time for networking. So from now until the cocktail at 6, you can meet in this room. You can also meet in Baobab 1, which is just over there. And then also in the business lounge on the 3rd floor. So if you'd like to have side meetings, you can do that. And then we'll start tomorrow morning at 9 o'clock sharp. And so we have two sessions. The first is successes and challenges in adapting the ITN approved strategy, and then climate change and malaria is the second session. So thanks everyone for a good day one, and we'll see you tomorrow morning at 9.